如果有座长出现的话，我们帮你投在这也会。
是。
对。
你同时也是 speaker。
对。
啊你
我好像是有帮他去。
啊你刚刚去过那位的？
试片室。
对，去过了。还有找到他们秘书吗？
秘书？没有。
他可能要让你签那个。对，签。那你差不多快到了。
等一下，这边结束了。
你再过去找他。
你说秘书处？
对，就刚刚那个试片室的后面。
好，那边我还没去。
对，秘书是家里。
我等一下，这个session结束我再去。
有几个考完？最后一天要留下来吗？最后一天。
我可能明天大概中午我就会走。
4月1号不会回来。
应该不会。
好，我想有个闭幕有个晚宴弄下还要去密道，还要吐，难怪这么密道。有空下请他就再回来。
密道那个安正中就一直要去，结果
对，好像不错，蛮有意思。
结果 delay 了2次都没去成。
好，你看4月1号下要不要回来一下？提早放假。好，要1点半的，1点半。好啦，这次谢谢啊。
谢谢你。
可能没太多时间可以陪你啊。
没有。我后来有把那个 update 到2018。
真的好，谢谢。
你本来说我上一次我们2-3年前就是2015。
对啊。
那3年后，我现在把它整个 update 到2015。
太好了，对啊，谢谢。刚刚教授还提到说 CKD， 我们可能不是你这一部分，我们可能 CKD 的那个guideline可能肾脏科要重新做，我不晓得你有没有报在里面。
那个肾脏科那个吗？有啊。
有。
他
最近要开会。
我知道。
这边之后，看看要不要到时候找时间再来把这个仔细做。
我今天会要把那个我今天讲的内容就是 email 就赖给你。
好。
那你就看看如果有需要哪里需要再更新的是说哪里没有讲得很清楚。
好 ，OK。你把之后给他试着看。
好。
OK， 好。
今天的演讲顺序是这个李宗一先开始，
先是那个苏婶的
苏婶开始，
对对对，
他先放影片，
对，但他目前他也是座长，所以你们一开始先会有一个开场，对，然后你们开场结束之后才会放影片，对，那放完影片看你们有需要介绍下一位讲者吗？然后如果有需要，
就是这个李宗一嘛，
对对对，他是第一位，然后第三位是你这样。但是苏婶目前还没有上线，所以待会可能
上线的话你再。
好。
你好。
我想谈跟田佑林。
是，好久不见了。
再麻烦你这样。
没有。
哎，昨天住这里。
有，我昨天晚上就来，还好。
谢谢。
因为今天是早场的。
是。对呀。不过因为大部分还是 virtual 啦，我们现场的话几乎都是耳声的意思。
是。
所以可能搞不好今天早上才陆续各地会跑来。
你们开幕是今天下午？
今天对晚上，今天晚上。因为我们这次是跟另外一个IMNA国际的儿生一起办，所以昨天晚上开始一个 workshop， 昨天是开到11点，晚上，他是晚上7点多到11点，配合国际的。是。所以可能有人晚上的辛苦一点，早上就
没有问题，我们是面对全世界。
是，谢谢。
好，谢谢。所以在这边的话要，到时候就要用按，然后这边有荧幕嘛，
对，
这边有 slide 的。
对，然后会有这个剩下时间提醒这样子。你那边的荧幕也会，一场是30分钟，然后 Q&A 是20分钟。对。
所以我们如果在这边讲是要面对面对那个摄影机，
那个 camera，
面对那个摄影机。
对，那 Q&A 的时候大家都坐台下，都要看这一台。对，主要是给线上的人看。
我看今天这一场是没有听众，没有现场听众。那你们知道线上有多少人吗？
线上吗？目前吗？
我是说等一下了，就是说在节目进行的过程中，你们会知道说线上会有多少人现场。
现的，所以待会的话我会给你看，就是他的画面，可以直接用麦克风跟他对话，但一定要透过麦克风他才听得到。
你刚从高雄来，他从台南来。哦，你昨天也住这里。
你也是吗？
昨天也是有住这里，对，不然怎么赶得来？早上
有一点赶，但是。
Hello, can you hear me? Can you hear me?
Hello, hello, yeah.
Hello.
Professor Susan Firth.
Hello.
Yeah. Can you hear me now?
Yes, I can. Thank you.
Yeah, this is Zhi Shui from Taiwan.
Good morning.
Good morning. Good morning. Good evening, actually, in the US. Okay, so how can we proceed for this section? The first one, you are the first speaker, right?
Okay, yes. Would you like to introduce me?
I will introduce you.
Okay.
First, and then the next speaker is the Professor Lee. Do you have his CV?
Yes, I had a brief bio. I can introduce him.
Okay.
But I could also, then you're the third speaker, correct?
Yes. And also you introduce me.
Yes, I will introduce both of you. Okay.
Okay, no problem. And I heard from the secretary that you have a video for 17 minutes, right?
Yes.
Okay, but because everyone has the 30 minutes time. So after the video, do you want to speak anything on live?
Yes, I can answer any questions. I can make a few comments. So it actually felt a lot longer than 17 minutes when I did it.
Okay.
But yeah, so I'll just make a few comments after the video.
Okay, that's good.
Okay. So you'll introduce me?
Yes. So
okay.
So let's begin this section, okay?
I have one other question. Can you see me? Because I can't, my video. Okay, now you can. Okay.
I cannot see you.
I just turned
Do
the
you have
video
a
on.
video on? Yeah. Oh, yes.
Yeah.
Yes. Good.
Okay.
Good.
Okay, great.
You also
Thank
see me, right?
Yes.
Yes. Okay.
Yes.
So let's start this section. Good morning or good evening, everyone. Let me introduce the first speaker, Dr. Susan Firth. She is a MD, PhD, and she is currently is a vice chair of the Department of Pediatrics and the chief of the nephrology division at Children's Hospital of Philadelphia, and a professor of pediatrics and epidemiology at the University of Philadelphia. Dr. Firth received her MD degree from University of Pennsylvania. She completed her residency and fellowship at Johns Hopkins, where she also received her PhD in clinical investigation from Bloomberg School of Public Health. Dr. Firth is the principal investigator of the chronic kidney disease in children study, the largest multicenter prospective cohort study of children with chronic kidney disease ever conducted in North America, now in its 18th year. She has mentored many junior faculty who has progressed to successful research-oriented career in nephrology, urology, and rheumatology. And also she received a lot of awards. So let's welcome Dr. Susan. She wants to talk about the epidemiology and the database in chronic kidney disease in children. Okay.
Good morning. I'd like to thank the organizers for giving me the opportunity to present in this session about the chronic kidney disease in children study. The CKID study is an observational cohort study. We recruit children with chronic kidney disease up to the age of 16 at study entry from over 50 sites in the US and Canada. It's an observational cohort study. Our goals are to recruit and retain children with chronic kidney disease, to define risk factors for chronic kidney disease progression and the effects of kidney disease progression on cardiovascular disease risk, neurocognition, development, quality of life, and growth failure. The study was initiated in 2003. We recruited the first cohort starting in 2005. That cohort was 586 children with a median estimated GFR of 44. 3/4 of the children had non-glomerular diagnosis and a duration of CKD with a median of 8.6 years and an age of 10.9. To complement that group, in 2012, we started to recruit cohort 2. This was 305 children with a higher estimated GFR of 66 and a shorter duration of chronic kidney disease of 6.2 years. The median age of that group was 12. To further define the characteristics of childhood CKD, in 2017, we opened recruitment again and recruited an even younger group, all with non-glomerular disease, who had a median duration of CKD of 3.4 years, most of whom had CKD since birth. The outcomes of our study were really kidney replacement therapy, or alternatively, a 50% decline in GFR. We also looked at annualized GFR ratios, so the change over time in measured GFR. Initially, though kidney replacement therapy was a study endpoint, in our most recent iteration of the CKID study, we've continued to follow subjects through initiation of renal replacement therapy so we can characterize the effects of growth, the effects on growth, and as well as development, cognition, and cardiovascular disease risk. Even for those children that we've not been able to follow in person, we've developed a number of mechanisms so we can look at long-term outcomes as these children that we enroll become adults. We had in 2013 instituted a mechanism for passive follow-up. Even if children could not come back for study visits, we allow for phone or video visits. And at that time frame, we also added a consent to link the data from the CKID study to some existing registries, in particular, the US Renal Data System Registry, where we will, many years from now, be able to ascertain long-term outcomes, including initiation of dialysis or transplant, need for dialysis again after transplant, and also potentially endpoints like mortality. We collect data at annual study visits, with the exception that the first year we do 2 visits in 6 months. You can see we alternate our focus on direct measures of kidney function and establishment of clinical phenotyping of cardiovascular disease risk factors, including ambulatory blood pressure monitoring, evaluating for dyslipidemia and effects on the heart with echocardiograms, and then also in-depth cognitive evaluation, behavioral assessment, Tanner staging, and at each visit, we biobank blood, plasma, serum, and urine for further studies. Over the years, CKID has made a number of seminal contributions to the study of chronic kidney disease in children. We've introduced methods to directly measure GFR with the plasma disappearance of iohexol, a number of means to estimate GFR accurately and precisely. We've defined risk factors for kidney disease progression, the prevalence of cardiovascular disease risk in children, as well as clarification on the evolution of bone and mineral disorders in CKD and the effects on cognition and quality of life, and have most recently begun to partner with others to look at genetic contributions to structural kidney disorders, as well as genetic risk factors for progression. In 2009, we published a set of equations led by George Schwartz to estimate GFR in children. The updated bedside formula of 0.413 times the height over the serum creatinine has become a very useful tool. Additionally, we have a more in-depth formula outlined here that more precisely estimates GFR from creatinine and cystatin. In the current year, we just published in KI a new model to estimate GFR that has very little bias and is highly accurate up to age 25. And to do this, we used over 2,500 observations from almost 1,000 individuals, and we developed a creatinine-based equation and a cystatin-based equation that can vary with age and sex so that we get more accurate estimates. The graphical description of measured GFR compared to the creatinine-based estimated GFR here on the left panel, or the cystatin-based estimated GFR on the right, is illustrated here, showing very little bias and extremely high correlation for each of these equations across the age spectrum up to age 25. And we've made this calculator available online at the website illustrated here, where you can enter age, sex, and then either creatinine and height or cystatin and get an estimate of kidney function. Additionally, we recognize that proteinuria is a important risk factor for kidney disease progression. Different formulas use proteinuria or albuminuria to look at estimates of kidney function and also risk of progression. We've shown the correlation between levels of proteinuria and albuminuria in a more recent publication in AJKD in 2020, showing that we can use these measures almost interchangeably with these estimating equations. We partnered with the ESCAPE study to combine our data on children with chronic kidney disease with the children enrolled in ESCAPE, and we were able to classify children by level of GFR and baseline urine protein to creatinine ratio into different risk stages, with the lowest risk of renal failure, imminent renal failure, in those with the highest GFR and lowest level of proteinuria, and the most accelerated risk in those with lower levels of GFR and more advanced proteinuria. And we were able to use this data to develop a clinical tool that, according to risk group, gave providers and families estimates to the time needed before an individual would be at risk of developing renal failure. And this could be used in the clinical setting to help with planning for need for transplant or initiation of dialysis. And in a paper back in 2015, we identified a number of biomarkers that predict rapid progression of kidney disease in children both with non-glomerular and glomerular disorders. And this slide shows those factors that are risk factors for a faster time to needing renal replacement therapy. Older age, male sex, both associated with a quicker need for renal replacement therapy, as well as elevated and nephrotic range proteinuria. That was in children both with non-glomerular and glomerular diseases, hypoalbuminemia, risk of elevated phosphate, as well as elevated blood pressure associated in all the children with higher risk of progression. Additionally, anemia and dyslipidemia were factors the estimates were similar in both populations, but statistically significant and associated with more rapid progression in children with non-glomerular disorders. We looked at factors of bone health and shown that elevations in FGF23 actually precede elevations in phosphate or intact PTH in children with CKD at every level of GFR. And based on this, we've also looked to see, we've shown that higher FGF23 levels are associated with more rapid progression. And as a result of this, a new clinical trial is currently underway to use phosphate binders early in the course of CKD to see if we can both lower FGF23 levels and slow progression to end-stage renal disease. As I mentioned, we partnered with ACPN to look at risk factors for progression. We also used our observational data and measured blood pressures in clinic to look at the correlation between achieved clinic blood pressure and kidney disease progression in children. And we've shown that achieving, based on our observational data in CKID, achieving a clinic blood pressure with systolic or diastolic blood pressure below the 75th percentile was associated with protection against renal failure. And so this actually adds to the existing ACPN trial where the direct measurement of blood pressure with 24-hour mean arterial pressure was the exposure, but sometimes difficult to obtain repeated measures of ambulatory blood pressure monitoring in children with CKD. So now we can target achieved clinic blood pressures as another parameter to try to slow progression. In looking at growth and factors associated with adverse growth in these children, we've shown, as others have, that lower CO2 is associated with poor growth and something that's potentially targetable to improve growth and other outcomes. And we've shown the associations between neurocognitive dysfunction and CKD, with a high proportion of our children, more than one standard deviation below the mean in a number of measures of performance IQ, particularly in block design and numerical operations, showing perhaps that some more complex intellectual operations are impacted by CKD. We've also shown, based on quality of life data, both from the child and parent perspective, that there are substantial impacts of CKD on children, particularly in school performance and also in overall health and social and emotional development. As we all know, in adults, cardiovascular disease remains one of the leading causes of death in children with end-stage kidney disease. So one of our goals in the CKID study has been to assess how cardiovascular disease risk factors evolve in the course of CKD. We've shown that elevated BP is highly prevalent in children with CKD, and we've seen evidence of target organ damage, both in left ventricular hypertrophy, with a dose response relationship between normotension, masked hypertension, and confirmed hypertension, and LVH. Additionally, we've shown that higher levels of FGF23 and different tertiles of FGF23 are also associated with more elevated, higher levels of left ventricular hypertrophy. Again, another compelling factor for the trial that I mentioned earlier to see if we can slow progression and actually also target adverse cardiovascular outcomes. Finally, we've partnered with a number of other investigators to look at the contributions of genetic disorders in chronic kidney disease in children, and have found that despite clinical diagnoses that weren't necessarily associated with genetic diagnoses, we found a number of previously unrecognized genetic disorders in our cohort, particularly in those with congenital urologic disease. And this slide illustrates a number of the discrepancies between clinical diagnoses of disease. For example, individuals thought to have FSGS or HUS, or non-specific diagnoses like reflux nephropathy or chronic GN or obstructive uropathy that have been found instead to have underlying genetic diagnoses. Additionally, many of the copy number variants and potential genomic disorders that we identified in the CKID study have also been associated with neuropsychiatric disorders, and partnering investigators have looked to see at the association between being a carrier for one of these genetic disorders and performance on our neurocognitive assessment, and have been able to show an association between having one of these genetic disorders and adverse effects on performance. Again, showing perhaps that there's an underlying genetic contribution to some of these deficits that we're seeing. Importantly, we were also able to show that interventions at the level of the child with more intensive learning opportunities and monitoring were able to mitigate some of the deficits that were otherwise seen in carriers of these genetic disorders. Finally, partnering with Neptune, we were able to show the risk of accelerated GF to R decline associated with having high risk APOL1 two high risk alleles. And you can see here the dose response relationship between having two high risk alleles and a more accelerated decline in GFR, both in the CKID cohort and the Neptune cohort. Finally, I want to end by showing some of the opportunities that we've uncovered in the CKID study. Despite showing you'll see in this diamond plot on the lower right side, more advanced risk stages from A to F, we've shown that even in relatively low risk stages, we do have evidence of a number of cardiovascular risk factors, elevated blood pressure, high levels of phosphorus, high levels of acidosis and anemia that although present at low levels of GFR are not frequently treated as much as they could be. And we see gradually as kidney function declines, we see a higher proportion of the population treated with specific therapies for these disorders. But we see here in our observational study an opportunity to improve care for these children with chronic kidney disease, to improve their ultimate outcomes and slow their progression to end-stage disease. With that, I'd like to thank the organizers for giving me the opportunity to speak today, and I welcome any questions.
Thank you. Thank you for your wonderful talk. Do you have any questions in the audience, from audience? And online audience also.
So So I can see the discussion forum if people would like to enter questions there. I did want to add that a couple of our more recent focuses in the CKID study, really one of the most remarkable findings, I think, of this cohort now that we've recruited over 1,000 children is that even from a young age, a median age of 11, these children have a remarkable constellation of cardiovascular disease risk factors. And in addition to those that I mentioned in the talk with hypertension and left ventricular hypertrophy, we do see evidence very early of diastolic dysfunction, and we're continuing to evaluate target organ damage in the heart using cardiac MRI. And so those results are currently being analyzed. Additionally, we've examined, looked for vessel stiffness with pulse wave velocity. And though the good news is that we haven't found a great deal of increased stiffness, we have found, particularly in those children with high levels of proteinuria, we found some suggestion of more rapid pulse wave velocity. So showing that there's, again, even at a young age, some impact on the vasculature from in children with chronic kidney disease, particularly those with heavy proteinuria. The additional work that we're doing now in looking at risk factors for progression is looking at plasma and urine biomarkers that over and above estimated level of kidney function and proteinuria predict decline. And this is work that's being led by Dr. Jason Greenberg from Yale, partnering with me and Dr. Michelle Denberg in the Biomarkers Consortium. And we're finding that high levels of urinary and plasma KIM1 and plasma TNFR1 and TNFR2 predict chronic kidney disease progression. And urinary EGFR actually seems protective. So this work is now, we're hoping to develop panels of biomarkers that, in addition to creatinine or cystatin and levels of proteinuria, will be able to help us more accurately predict long-term outcomes for children with chronic kidney disease, and will also potentially, if we can identify patterns of children at high risk, allow us to select children that may be good candidates in trials of new therapies that may slow progression. So that's the general direction we're heading with our study.
Yeah, I'm very impressed for the wonderful result from your CKID cohort. I want to ask you that in 2009, you said that you developed a new equation for the child to estimate the EGFR, right? And I think all of the cohort are from the CKD children, right? Do you have any non-CKD children contribute to the new equation development?
That's a really excellent question. No, the answer is that we have developed the equation within the CKID study. So all of the participants did have some degree of chronic kidney disease. In 2009, the initial equation, those children did have more advanced kidney disease. So with a median GFR around 40. Now, with the equations that we most recently updated in just this year that are published in KI, we have children with much more mild kidney disease, so estimated GFRs as high as 90. So there is a broader spectrum of children with kidney disease, but your point is very well taken. I think our equations, having been developed in children with some element of chronic kidney disease, it is a little bit risky to apply them to the general population. We have seen in the past that our equations tend to underestimate kidney function in those with really normal function. So I think it's an important point to keep in mind. And I'm curious if that was your the basis of your question as far as extrapolating these equations to the healthy population.
Yes. And in your cohort, do you have any Asian population?
Also, another important question. No, well, a fraction of, in the US, I think in our cohort about 70%, 75% self-report as Caucasian, and maybe another 25 to 30% as African American. And so there's a small proportion of individuals who identify as Asian American, and they would be from a large group. I think in the US, individuals who would identify as Asian could be from Southeast Asia, and very broadly. So that is another important point about extrapolating to a different population.
Yeah. Another question is that, what do you think the diabetes contribute to the CKD in child?
In our study, actually, we didn't enroll any children who had CKD related to diabetes. In the US, I mean, traditionally, type 1 diabetes has been, and kidney disease related to type 1 diabetes has been quite uncommon. Unfortunately, we are seeing more and more type 2 diabetes and some associated kidney dysfunction in children with proteinuria, often early on, or albuminuria. But in our particular study, we have not enrolled many children with CKD secondary to diabetes, and it's not a largely prevalent population. Hopefully it won't be, but one has to be concerned with the prevalence of diabetes that we're seeing in the US.
Okay, any questions from the audience? So if no, and thank you, Dr. Susan first. Let's move to the second speaker, Dr. Lee. Please introduce Dr. Lee.
Thank you. It's my pleasure to introduce Dr. Lee, who is a professor in the Department of Public Health at National Cheng Kung University. Dr. Lee got his PhD in epidemiology and biostatistics at McGill and is currently a counselor and I believe also the deputy director for the International Society of Environmental Epidemiology. And Dr. Lee will speak this morning on the potential for population-based health data in maternal and child health epidemiologic studies in Taiwan.
Thank you, Dr. Susan first. My name is John Lee. I'm here not to talk about the pathophysiology of pediatric nephrology, but I just want to let you know that there is a potential for the population-based health data in Taiwan to do research related to the pediatric nephrology studies. I'm going to talk 3 parts of topics. The first one with the past. At the local research here, we are all aware of the National Health Insurance claim data. A lot of people here are doing the research with this data set, but there are some problems with this data set. So beginning from 2013, there will be a new opportunities for the researchers here in Taiwan to do more studies, not only the NHI data set, but also the other health data sets. And then I'm going to present my perspective of the future studies here. So let's begin with the first one. We know that in Taiwan, we launched the National Health Insurance in 1995. So almost everyone in Taiwan are covered by this National Health Insurance coverage. So every day is produced a lot of data set, not only for the ambulatory care, but also for the inpatients. And the NHI covers not only for Western medicine, but also for the dental care and Chinese traditional medicine. So it's really a nice programs here in Taiwan, always with satisfaction rate of people more than 90%. Everybody are happy with these programs. And also it's makes the reality come true because WHO focus on the primary care, and here in Taiwan, we do have a very good quality of healthcare in all settings. So the data set is huge. Let's take the data set in 2000 years. It covers a lot of data set, not only for the outpatients, but for the dental care, Chinese medicine. So almost all the clinics and hospitals were covered by these programs, and it produced nearly 900 gigabytes in a single year. This doesn't include the image data. If the image data include, the size of data will be huge. In terms of the publications, we can see that the first publication was in 2001, which is a paper related to the dental care. But you can see that beginning from 2014, the number of publications by using the NHI dataset become flat, not increasing, and a little bit decrease. That's the reason because we know that there are a lot of problems with this dataset because the information is not so complete. For example, there's no any pathological confirmation of the cancer in the NHI. We have to have that information from cancer registry. And also a lack of some very important lifestyle variables in the NHI dataset. We don't have the BMI, alcohol consumption, or even smoking. And also some important clinical data were lacking. For example, in the maternal and child health research, we do not have the gestational age, which is very serious problems every time when you're talking about the maternal and the child health research. And also the causes of death. There is no such information. If you're going to see the all-cause mortality, that will be fine. But if you're going to look at the specific cause of death, the NHI is unable to provide this information. So because of that, or even of that, still a lot of local researchers in Taiwan, they did a very important research and published in a very good journal and have a very important influence on the clinical practice. So beginning from 2013, just last week, I mentioned there are a lot of limitation in the data of NHI programs. So the government, the Ministry of Health and Welfare, they trying to organize the national population-based data set. So they set up a data center which is called Health and Welfare Data Science Centers. With this data set, they're trying to manage all, not all, but most of the population-based data in Taiwan together so that will improve the quality of data substantially. And I will focus on one data set, which is called the TMCHD, which is the Taiwan Maternal and Child Health data set. And this data set is very unique because before this data set was set up, there is no any study that can link mothers and children in Taiwan. So that's beginning 2014. The Ministry of Health and Welfare started to do this work. And up to now, there are totally 106 different data sets from different ministries. So you can see the coding book from the website. So I will call this is a kind of life course data set from the birth to the death. So the NHI is only one of the data set, but it's the biggest one because everyone, to see the doctors. So it's very big. But if you're going to have a complete information, the red one here, it shows the survey data, not the register data. And the blue one here are register data. And all the data here are linkable. So if you're going to see the lifestyle, you should go to the National Health Interview Survey, the NHIs. It can be linked to the NHI. So you will see the relation between smoking and the disease. And also you can use the traffic accident registry, which is a data set from the police department. So you can use this data set to explore the relationship between alcohol, drinking, driving, and the mortality. So all the data set here are linkable. if we categorize those data sets, it can be the data set for the healthcare providers and also the hospital informations. Some data set provided socioeconomic, cultural, and behavioral factors. Of course, there are some family factors. So the red one, the red circle here is maternal and child health data that I'm going to talk about this in more detail. And also we have the data set for some specific diseases such as HIV, AIDS, and also for the rare disease data set for all the diseases with the incidence rate of less than 10,000, they have a data set to keep all the records. Of course, Taiwan Cancer Registry is also another type of specific disease. And we also have the data for specific populations. For example, we have the original people data set, so we can have the health information for all the people from original tribes. All the data were kept in the Ministry of Health and Welfare, and the people are not be allowed to take the data out. So every time when we are analyzing data, we have to go to the centers. And the center is located in Taipei, so people in different areas of Taiwan, they can use the branch. So now totally we have 10 branches around the countries. And in Tainan, where I'm living, we do have a branch at the NCKU hospital, so we can use this data set. The reason for the government not to giving the data away to the research is simply because of the security considerations. Because now it's easier to get all the data linked. So that will be a chance, given an increased chance of the breaking the confidentiality. So that's a big problems for the people are concerned about the safety of the data. So that's the reason why all the researchers have to analyze the data within the center and would not be able to bring the data out. So that's caused some inconvenience for the local people here because the centers open only from 8:30 to 6:30 p.m. So in office hours, so you are not allowed to analyze your data during the night or during the weekends because during those off work times, the centers are not open. And this is the only chance. This is one of the data set that in the beginning, myself, because I did a lot of maternal and child health research, and I like to see the linkage between mothers, fathers, and the children's, because a lot of children's diseases are probably due to some kind of exposures of their mothers or fathers. And the birth certificate register is a register supervised by the Ministry of Interior. And this is the only data set that can link parents and the children's. And it's very unfortunate that when I look at the data set, I was so sad because the Ministry of Interior, they use a serial number, which are not unique. So the different cities and counties, they are using the same serial numbers to mothers or fathers who are not the citizen of Taiwan. And we know that there are now more than 10% of mothers here in Taiwan are not Taiwanese citizens when they are giving birth, and less than 2% of fathers who are not Taiwan citizens. So they are unable to use a unique ID to link the children's. So we spend a lot of time trying to find out who are those non-Taiwan citizen mothers and fathers. And we're using some kind of algorithm trying to find out those persons. So these are the 4 data sets we use. And also we validate the algorithm that we use. And the results are quite useful, quite valid. So now the Ministry of Health and Welfare, they use our algorithm to update this data set. So now the local research here can use the data set to do the research about the maternal and child health. And in this, when we are doing this data linkage, we just trying to take a practice of the data set. So this study was done by Dr. Zhou. He's here. He's a pediatric nephrologist, and working with Dr. Zhou, we do a research about the association between maternal chronic disease during the pregnancy and the risk of CHD in their children. Well, this study was just copy the design of one US study just published in Circulations in 2014. We just copy exactly the same methodology and use the Taiwan's data to answer this question. So unlike the cohort just mentioned by Dr. Sudan first, her cohort is 1,000, but it's very detailed information in her cohort. But here we have like 418,000 pregnancies over 7 years of period. So we have a very huge data set, which is good for some rare diseases and also that can address some specific questions. So using this cohort, we did identify a lot of children suffering from congenital heart diseases, and some of them are severe forms and some of them are mild forms. And all those diagnoses were based on the ICD code done by the doctors in the hospitals. So we do use some algorithm trying to validate those diagnoses. And we can see that a lot of chronic diseases suffered by mothers are associated with the risk of CHD in their children, especially for the mothers with type 1 diabetes, type 2 diabetes, and of course the mother themselves suffering from congenital heart defects, which are also related to the risk of children's CHD. If we divided our endpoints into mild CHD and the severe CHD, because of the sample size, we do not see many significant results for the severe CHD in relation to maternal exposures to certain chronic diseases. But again, the type 2 diabetes of mothers and the congenital heart defects of mothers are both significantly associated with a highly increased risk of severe CHD of their children. Because of that, we published that paper in 2015, and I think it's 2 years later, I get a message from a team from the USA, from UCLA of the United States, led by Dr. Julia Heck. She is an epidemiologist in pediatric cancer research. Well, the local research here is Dr. Peizhen Li. She is a professor with the National University of Nursing and Health Sciences in Taipei. Because Peizhen, she's doing her postdoctoral training in UCLA, so I guess they are longtime friends. So one day, Peizhen told me that a research team from UCLA is highly interested in the data set here in Taiwan. As I said, we're not allowed to bring the data to the United States. So all the data must be analyzed here in Taiwan. So we just have a model of cooperation between the Taiwan side and the US side. We analyze data and we discuss on the internet about the study design, and we work together to draft in the manuscript. And so far, it's quite successful in such cooperation models. And this study is focused on the parental comorbidity, and particularly for the mothers who use some pharmaceutical uses during the pregnancy, and they focus on the risk of childhood cancers. In California, there are 38 million people, which is almost 1.5 times greater than the population size in Taiwan. But Julia told us that there is no such chance for the research in California to make the linkage of so many different data sets. So they are highly interested in the data set here in Taiwan. So we just applied the data from 2004 to 2014. Taiwan, we have 230 1,000 births per year, roughly. So totally we have 2 million and 79,000 births during this 11 years of period. We use the National Health Insurance claim data, also use a birth notification, which are including the information about the maternal comorbidity during the pregnancy and also for the stillbirths of mothers. And we also use the cancer registry and, of course, the death registry. So all the 4 data sets were combined together for this research. Of course, we use the Taiwan maternal child health data set because this is only one data set, as I said, that can link mothers and children. This is the paper that published last year, which is to look at the spina bifida, which are the neural tube defects because of the spine and spinal cord do not form properly for the children's. So the team is looking at the association between the spina bifida and pediatric cancers. And also, this team has some research from Denmark. So actually, what we have been doing is to compare the results from Taiwan with the results from Denmark, which I think is very unique because different populations will have different social backgrounds and also under the different medical care systems. So you can see it's very small, but you can see in the green one is the result from Denmark data. Denmark has only like 8 million people, which is less than the population size in Taiwan. And we use 11 years from 24 to 2014. In terms of all cancers, we can see the odds ratio is about 8.5 to indicate the positive association between the spina bifida and pediatric cancers. And from the Denmark, they have a large number of childhood cancers, but they use like 27 years. So they got exactly the same odds ratio, 8.4. But the confidence interval are both wide for the result in both countries. That's because these symptoms or disorders are very rare. So, but again, this kind of cross-nation comparisons provide the reassurance that the results are considered valid. We do have another studies published in International Journal of Cancer, also last year. They are looking at the gestational risk factor for childhood cancers. And Julia Heck is so ambitious because we have, just as I said, we have more than 2 million people. So during the 11 period, we link to the cancer registry, we identify 1,900 cases of cancers. It's huge because the cancer in children are rare. So for the 1,900 cancer cases makes Dr. Julia Heck so ambitious. So she decided to use a different endpoints, not only the leukemia, which is common in children, but also some CNS brain tumors, and also neuroblastoma, retinoblastoma, hepatoblastoma, and germ cell tumors. So you can see that we can examine the association between the childhood cancers with specific gestational parameters like birth weight or the gestational age. And I circle here, you can see that the numbers in the circle is very small. So the number in the green circles are less than 3, and there is no data for the cells with the red circles. That's because the government of the data center of the government will not allow us to bring the small size of data out for the security. So the reviewers are just curious about why you do not put the data in this cell, just because of the security of the data. So basically, we find that the parity are positive associated with the acute myeloid leukemia, central nervous system tumors, and neuroblastoma. And also, we find that the birth weight are also associated with the hepatoblastoma, germ cell tumors show a significant rural and urban variations, and the children living from the rurals have a higher risk of germ cell tumors. So the conclusion is that despite that Taiwan has lower rates of both high and low birth weight compared to the other Western countries, but this studies does observe several similar associations that reported from Western countries. So this is again an example showing that we can do a cross-cultural or cross-country comparison in terms of the association of maternal exposures and the childhood cancers. This study has almost been accepted. I think it's under the second revisions, looking at the familial viral hepatitis. 20 years or 30 years ago, the prevalence of hepatitis B and C are so prevalent in Taiwan. But I think beginning from 1983 or 1984, there was a mass vaccination programs in Taiwan. All the children, all the babies got shot when they are birthed. So the prevalence of hepatitis B is getting decreasing since 1984. And hepatitis C still problems in some areas, but not all. But in this study, we do find that some mothers are still suffering from viral hepatitis. You know, one-shot vaccination doesn't guarantee that the lifetime protection of the hepatitis B. So we just use this data set to see whether or not the mother's hepatitis B and hepatitis C have some kind of influence on the children's cancers. And we do find that it's non-significant, but there is a 50% of increase of the children's cancer if the mothers are suffering from hepatitis B or C. But when you're looking at specific type of cancer, the number is very small. So almost cannot reach any firm conclusions about maternal hepatitis B infections and the childhood cancer. And the fathers viral infection also associated with the children's cancers, like fathers have hepatitis B and hepatitis C are associated with a significant increase of non-Hodgkin's lymphomas among their children. And also the soft tissue sarcomas are also associated with father's hepatitis B and hepatitis C. Of course, if the children themselves have the hepatitis B or C, they have a high risk of getting all cancers, especially for the hepatic liver cancers. We can see that the hazard ratio is more than 37. So still, there are some children in Taiwan are suffering from viral hepatitis infections, and those children are very vulnerable to certain type of cancers. And we also include the information from Denmark. But the Denmark, the data are very sparse. They are unable to make any firm conclusions. We do see some tendency, but all the results are non-significant, just because they do not have such large numbers here. The last one will be the futures. A paper published in JAMA Internal Medicine are talking about the strengths and limitation of population health data. And these studies particularly compare the data set between Taiwan, Sweden, and South Korea. And we can see that the Taiwan's data set now under the supervision of Ministry of Health and Welfare, we do share some strengths with the data set from Sweden. But we do have some strengths is the one that I highlight with the blue and the red circles. We do have a survey data. We have a nutritional survey data. We have the health behavior survey data. We have the drug abuse, the drug addiction survey data, which are done on every 4 years on a regular basis. And those national survey, which are based on the nationally representative data samples, can all be linked to the population data set, which can, to broaden the scope of our research questions. more than that, the government are beginning from last year, I guess, or the year, 2 years before. Now they started to open the image data for the research use. So now a lot of AI guys, they are trying to use the image data or the laboratory data, trying to find some prediction models for the clinical research. So my dream for this Taiwanese population data is the life course epidemiology. We know that Professor David Barker, who proposed this theory about the fatal progression theory, and I saw that there is also topics. I saw the agenda just a couple of minutes ago. I saw agenda. There is also one speaker here talking about the fatal progression theory, which could also be related to the childhood nephrologist diseases. So now every time we're talking about disease in the middle or older ages, but for example, the people who have rapid decline in lung functions, this may not be necessarily the cause of occupational exposure or air pollutions, but it could be traced back to the exposures in the early years, perhaps during the very early years, even during the pregnancy. So the disease occurrence could happen through the biological pathway or the social pathway. And with the national data set here in Taiwan, we do have a chance to see this kind of research in the futures. So the concluding remarks for me is that in the big data era, the population-based secondary data can play an important role, not only in public health research, but also in clinical studies. And to enhance these cross-cultural and cross-ethnic comparisons, I do see the hope or the potentials for the pediatric nephrologists in this group can work with other countries and may consider to set up the international cooperative studies with the local research or clinicians here in Taiwan. And finally, population-based data are sometimes useful compared with a hospital-based data set, and I think everyone must be aware of the strengths and limitation of using the hospital-based data set, and that's also a chance for pediatric nephrologists to use this kind of study. Thank you very much. I will end my speech here.
Thank you very much. That is such a wealth of data. I wonder, can you, in Taiwan, do you have national screening for kidney disease with urinalyses in children? And I wonder if you can link that with long-term follow-up data.
We do have a screen data, but most of them are cancer screening. For the children's kidney disease screen or kidney function screen, I would say no, not specifically for that specific group. So very unfortunate that at this point stage we do not have that screen data available for the pediatric nephrologist. Right? Am I right, Dr. Perfect? Yeah. Yeah, our moderator will be knowing about this much more than me. Yeah, Professor Xi said that, yeah, there's no such data available.
Also, I'll just comment, the imaging data will be a huge wealth of real opportunity for looking, like you mentioned, with AI for biomarkers of disease.
Yeah. Now, I think as far as I know, now most of the local researchers are using image data are from the engineering, not for the medical scientists, because most of the research now they are using the AI. But eventually, I will say that any products from AI will be applied to our daily clinical practice. So probably the next steps, some medical researchers here in Taiwan will start to cooperate with engineering guys to work on the research on the image data.
Okay, thank you. So I think we should move on to our next speaker, and it's my pleasure to introduce my co-moderator, Dr. Chi-Chen Xu. who is received his Doctor of Medicine in Taiwan and his Doctor of Public Health at the Tulane University School of Public Health. He is currently the executive director of the National Health Research Institute and also the director of the Institute for Population Health Sciences. His work is really remarkably well known. He has over 270 publications and more than 5,000 citations. His work covers broadly environmental exposures, metabolic syndrome, diabetes, tobacco exposure, and kidney disease, mineral and bone disorders. So it's my great pleasure to introduce Dr. Xu and his talk on epidemiologic patterns of end-stage renal disease in children in Taiwan.
Thank you. Thank you, Dr. Susan, for kind introduction. Good morning for the audience in Taiwan and good evening for the audience in maybe Europe or in the US. Today, I'm talking about the epidemiological pattern of the end-stage renal disease in children in Taiwan. I want to cover two subtopics. One is the epidemiological pattern of ESRD, and the other one is that what are the challenges we are facing in reducing the ESRD burden in Taiwan. As you know, that Taiwan has a very high incidence and the prevalence of the dialysis for the entire population. Here, the figures show that the incidence of the treated ESRD in Taiwan is more than 500 per 1 million population. This is almost the number one in the world. For the prevalence, currently about 90,000 patients with chronic dialysis in Taiwan, and the prevalence rate is more than 3,500 chronic dialysis patients per 1 million population. This is far ahead of Japan and the United States. For the past 15 years, Taiwan is always the top in the world for the instance of the chronic dialysis. Since it's less than 400 in 2003, and now it's more than 500 per 1 million thousand. So during the past 15 years, the increase, 33% increase. And compared to the United States and Japan, the increase is about 14%. So Taiwan, the problem of the chronic dialysis, ESRD, is very big. For the prevalence is also the number one in the world for Taiwan. For the past 15 years, 88% increase for the prevalence of the ESRD, and compared to the Japan and the United States, they are increased by about 47 to 56%. So, however, when we look at the crew incidence rate, it's increased a lot. However, if we use the age-adjusted incidence rate, we can see that actually they are a little bit decreased. So we know that the high incidence rate of the ESRD is largely contributed to the aging population. For example, if we break down the age category, we can see that for those who are older than 65 years old, then for those who are in age 65 to 74 years old, every year increase about 0.2% for the dialysis incidence rate. And for those who are older than 75 years old, then actually the increase rate is about 3.2% every year. And for those who are younger than 65 years old, the incidence rate actually is decreasing. especially for those who are younger than 40 years old, decreased by 0.9% every year. So when we look at the younger generation, for those who are younger than 20 years old, then the rate is even lower. They decreased for the last 18 years. The rate has been decreased by 45%, equivalent to about 2.5% per year decrease. And the major contribution is for those who are between the age 12 to 19 years old. The rate has been decreased from 16 in 2000 to about 6%, 6 per 1 million population in 2018. On average is about 3.5% decrease per year. So because the incidence rate for the young generation is decreasing, so for the number of the ESRD, for the prevalent case for those who are younger than 20 years old, the cumulative ESRD number has been decreased. In 2018, is about 106. This is not count if the patient is getting older than 20 years old, then we don't count for the for the ESRD person. But if we leave off the age limit, there were another story. For example, if we count for those who are younger than 20 years old, then the ESRD prevalence has been a little bit decreased. In 2018, it's 24.3 per 1 million population. But if we don't use the age limited, for example, the ESRD prevalence for those who started dialysis before 20 years old, then we can see that the cumulative incidence rate, prevalence rate has been increased by 161% for the last 18 years. Currently, in 2018, is 25.4 per 1 million population. So in terms of the number, currently is about 600 for 600 chronic dialysis patients for those who started dialysis before 20 years old. So the cumulative number has been increasing a lot. However, if we compare the entire population in Taiwan, currently is about 19,000 chronic dialysis. So the 600 is just a very small. It accounts for about 0.71% for the total chronic dialysis population. In terms of the survival rate for those who started dialysis before 20 years of age, you can see that for those who are younger than 6 years old, then the 5-year survival rate is about 50%, and 10 years survival rate is about 45.8%. However, if the children are older than 6 years old, for example, the 6 to 11 years old, then the 5-year survival rate is about 78%. And for those who are between 12 to 19 years old, then the 5-year survival rate is about 90%. 10-year survival rate is 80%. So the 5-year survival rate in Taiwan for the chronic dialysis patient is actually very good compared to the United States. If we compare to Taiwan, between Taiwan and Europe, then you can see that for the older patient, those who are older than 65 years old, 45 years old, then the survival rate is always better in Taiwan. However, if we look at the younger generation, for example, for those who are younger than 20 years old, then the 5-year survival rate in Taiwan actually is lower than in the US, in the Europe. The reason why to have this result, I think, is the lower transplantation rate. For example, the kidney transplantation per 1 million population in Taiwan is is about 12. It's very low compared to the international features. If we count, it's about 4 per 1,000 dialysis patients. So it's about in the bottom of the in the ranking of the world. When you look at for those who are younger than 20 years old, the young ESRD patient, then the kidney transplantation rate is a little bit higher. It's about 7 to 8 per 100 dialysis patient. However, you can see that in 2018, the number is surged to 15. But this is only 1 year. We have to continue observe if they can persistent to have this high number. Another issue is that for the young patient with ESRD, the hospitalization rate is increasing year by year. In 2018, it's about more than 2,600 hospitalization per 1,000 dialysis patient. And in other words, that every young ESRD patient have about more than 2 times hospitalization every year. And the admission rate has been increased year by year to about double in the past 18 years. Another feature for the young ESRD patients is that they have a much more resilience. In the adult population, we always say that once you have a first dialysis, then the 5-year dialysis-free survival is very, very low. I show the feature here that 1 year after the first dialysis, the dialysis-free survival is only 13%, and the 5-year is only 6.5% for the adult population. However, for those who are younger than 20 years of age, the first dialysis is not, the result is not so bad. The 1 year after the first dialysis, the dialysis-free survival is about 40%. And the 5-year dialysis-free survival is about 34%. So for the children, once they have a first dialysis, we still have to pay very much more attention to reduce the probability for them to get chronic dialysis. So let's make a very brief summary. Is that the incidence rate for the pediatric ESRD has been decreasing. Currently, it's 4.6 per 1 million population, and the prevalence rate has been increasing. Currently, it's about 25.4 per 1 million population. However, but it's increasing from 9.7 per 1 million population in 2000 and to 25.4 in 2018. The 5-year survival rate for the pediatric ESRD cases has been a little bit lower than in the Europe. The transplantation rate is still low. always less than 10%. However, in 2018, it's about 15.1% for the young ESRD patient. We need have a further observation. For the 5-year dialysis-free survival after the first dialysis is about 34.2% for young ESRD patient compared to those who are in the adult population is very good. So for the next topic, I want to talk about what is the challenges we are facing to reduce the high dialysis burden in Taiwan. As we know that the common causes of the ESRD between adult and the children is totally different. For the adult, the top 3 etiology is the diabetic nephropathy, the GN, and the hypertension. And in the child ESRD, the first one is the congenital abnormality. The second one is the GN, and the third is the genetic disease. So we also know that for the premature baby and those who have a low birth weight are more likely to develop CKD in their later life. However, when we look at the Taiwan's number, the rate of the premature birth in Taiwan has been increasing year by year. Currently, it's about 10% of the total birth. So if we don't pay attention to those who have a low birth weight or premature baby, then we can imagine that the CKD incidence in their later life will be increased. Another challenge I want to talk about for the CKD etiology is the diabetes and also the obesity. In Taiwan, about 45% of the instant dialysis patients can be attributed to the diabetes. Okay, and for the children, for the diabetes instance, for those who are younger than 20 years old, we can see that from 2005 to 2014, the increase, type 2 diabetes is increased by 18%. However, if we look at the bottom line, is 2008, actually is increased by 44%. So this is, as we know that for those who are younger than 20 years old, previously we always think they have a type 1 diabetes. However, currently the type 2 diabetes number has been increasing a lot. The reason for that is the increased number of the obesity. According to our government report, that the prevalence of the obesity or overweight for the students in primary school and also the junior high school is about 30%. So it's a lot. And for the obesity, the obese child can contribute. They are more likely to develop diabetes in their later life. And once they have diabetes, then the CKD, the diabetic nephropathy, is very close to their life course. Another problem is that sweetened beverage drinking. In Taiwan, for those for the senior high school adolescent, about 25% they drink sweetened beverage more than 500 milliliter every day. So it's a lot, and we know that for those who drink the sweetened beverage a lot, they also have a physical inactivity. They also have more likely to have alcohol drinking and smoking. So the risky behavior is always clustering together. And also a lot of biomarker has been abnormal for those who have a lot of a huge amount of the sweetened beverage drinking. For example, they would like they are more than for those who are have more drink more sweetened beverage, they are more likely to have a higher waist circumferences. They have more likely to have a higher BMI, higher blood pressure, and also higher uric acid. And all of these biomarkers are the risk factor of the diabetes and also for the chronic kidney disease. So if we are not care about our children, their healthy behavior, then we will wait for the development of the diabetes and the chronic kidney disease. For the International Childhood Cardiovascular Core Consortium, actually they observe more than 6,000 11 years old children for more than 23 years old. Then they found that for those who are originally have a normal weight, then only 15% in 23 years later they become obese. However, if originally they are obese, then in their adulthood they have more than 80% also can be obese. So we know that for the children, the obesity is a very real risk factor for the entire their life course. And they compare to those who are normal weight, who have normal weight in the children and also in the adult. For those who are obese in the children and the adulthood, they are more likely to develop type 2 diabetes, hypertension, dyslipidemia, and also the carotid artery atherosclerosis. So, and for the diabetes, hypertension, dyslipidemia, and carotid artery atherosclerosis are all the metabolic disorder are all the chronic kidney disease risk factors. So from this study, we also know that the body weight for the children is very important if we want to prevent the adult from developing chronic kidney disease. So let me make a conclusion. Is that the incidence and prevalence of the end-stage renal disease in the childhood is very small compared to in the adult population. However, if we don't pay attention to care the children, their behavior or their disease or we cannot reduce the ESRD burden in Taiwan. We need to pay more attention to premature or low birth weight babies. The second one is that we have to increase the health literacy for the adolescent and the younger generation patient to avoid them to drink more sweetened beverage, especially for our young children. And the last one is that we have to tell our mother to keep their children have an ideal body weight as early as possible, because once the children have obesity, then they will develop and they will keep the obese BMI carry this BMI into the adulthood. In the last studies, that more than 80% when the children has obesity, then in their adulthood they also have obese. So if we can pay more attention to this kind of feature for the child, then we hopefully can reduce the ESRD burden in Taiwan. Thank you.
Thank you. I think we are now open for Q&A. You can type questions in the discussion board. So actually, I will start. I had a question for Dr. Xu. I was struck by your graphic showing a decrease in end-stage renal disease in young people between the ages of 12 and 19 over the last decade. What are the explanations for that? I mean, it's a good thing.
Yeah, we are looking for a reason because I think the advance in the pediatric science is a very advanced. The pediatric clinical service is very advanced in Taiwan. So I think also the prenatal care is very good. So I think a lot of congenital abnormality has been reduced significantly. So we can see that this is maybe the major reason the pediatric ESRD number has been decreasing year by year.
And you mentioned the challenges with obesity and sugary drinks. So I think you did show that in the adult population is diabetes an increasingly common cause of end-stage renal disease in adults in Taiwan?
I believe so, because once they have a diabetes, then more than we have conducted a community survey for the diabetes patient in the community. Once they have the diabetes for the first time, they have already about 33%, about 1/3 of them have some kind of kidney problem, for example, for the microalbuminuria or actually for the reduced GFR. So once they develop diabetes, I think it's too late to prevent all of the patients from developing the chronic kidney disease. So for my opinion is that we have to prevent for the children starting from the children. If they don't get diabetes, then they will never develop diabetic nephropathy.
I think, yes, it's important prevention. And I had one other question for you about transplantation, and particularly in young people. And you showed that it's less common than in some other countries. I had two questions. One, are there different practices around transplantation that make it different than in other places? And then there was that, like you said, an acute rise very recently, or I guess in the last year of the data that you showed. Do you think that's a trend? Were there actions that were taken to increase transplantation?
Actually, from the NGO and the government are always encouraging kidney transplantation. However, for the long-term culture impact in the Oriental culture, they always don't. The willingness to donate their kidney is always very low. You can see the very similar situation in Japan, in Hong Kong. The transplantation rate is very, very low. I think this is maybe the culture. So we think the improving is gradually. Yeah.
Very good.
Can I make supplemental information to Dr. Xu? Yes, that's because the policy, because for the Chinese society culture, or for most of the culture in Asia, people are not willing to donate the body or donate the kidney. So in Taiwan now, as far as I know, we have only like 20% of the donors are from the corpse. For most of the donors are live persons. And in order to avoid the potential misconduct, the selling organs, so the government just have another policy regulating that only the people who have 5 degrees of relatives. So not everybody can donate the organs to people. So this makes it even difficult for the people in Taiwan, not only for children, but also for the adult people who are needing of liver transplant or other organ transplant. It's very extremely difficult. And another problem for the diabetes and the dialysis relationship, I think one of the potential problem is why diabetes accounts for so large a portion of dialysis in adults. That's because in Western societies, I know that, for example, in the United States or in Europe, the heart diseases are, incidence of heart disease is very high. So the diabetes will increase the risk of heart diseases, and also CKD also increase the risk of heart diseases. So for the patients with both diabetes and the CKD, they probably will develop a heart disease, for example, like acute myocardial infarction during the disease courses. And if those heart disease will take the lives of the patients away, then they would not have the chance to get the dialysis. But in Taiwan, we do not have high instance of heart diseases. So almost every patient with both diabetes and the CKD, even though they develop a heart disease during the disease courses, they probably not fatal. So finally, they will got a chance of getting the dialysis. And if there is such competing mortality events in the United States, probably the people will die from acute myocardial infarctions, and then will be no chance of getting dialysis in the late stage. That's what my comments.
I agree because the Taiwanese has a strong heart and a weak kidney.
Okay. Thank you. I had one other question for Dr. Lee. With the remarkable data that you showed and the linkage of data that's available in the current COVID epidemic, were you able to leverage, or the public health authorities leverage that existing data to very quickly look at consequences of COVID on the kidney and outcome and dialysis, and also from mothers to children? It's such a remarkable data resource that you presented.
Yeah, I think so. That's possible, but I have not yet seen any publication on these topics about COVID-19. What I know is that last year, in the very beginning of the pandemic, there is a letter to editor published in JAMA, I guess, JAMA or JAMA Internal Medicine. It's about whether or not the mothers during the pregnancy, if they got infected by COVID-19, should mother receive any medications? Because at that time, no confirmed information about the safety of the drugs, and people are just trying different drugs. And there's one person, I think it's from government, they just use a quick linkage about the mothers who, but Taiwan, a very small number of people are infected. I think the number is like 2 or 3, very small numbers. Yeah, and they just link to the outcomes of the mothers who were infected by the COVID-19 during the pregnancy, like 2% or 3%, very small numbers. So I think technically it's possible because data are already there, but they just need some time to apply for the data and need some time to analyze data. But I think the data are already there. It's possible.
The confirmed case in Taiwan up to now is about 1,000 only.
Oh my, that's wonderful.
So it's almost impossible to conduct the COVID-19 study.
Yes. It sounds like you had very effective public health measures early on.
I have a question to ask Susan because the C-kit is very impressive, very good. What is your suggestion to conduct a similar cohort study in Asian countries? Do we have to collaborate with the cohort in the Western countries, or we have to allocate some resources?
We would be happy to share our protocol and study forms that then we could collaborate and share data that was collected similarly. We'd be more than happy to do that. The study has been funded in the U.S. by the National Institute of Health, the U.S. National Institute of Health, National Institute of Diabetes and Digestive and Kidney Disorders. So it has been an investment, a relatively modest investment, I think, compared to some other large cohort studies, or certainly compared to clinical trials. But we would be more than happy to collaborate. The strengths of our study, I think, are that we recruit from many sites across the U.S. and Canada. We don't have a comparison group, so it is a little bit of a convenience sample. Children that present to the centers where we recruit and those that are willing to participate. But it's been a really successful collaborative effort across pediatric nephrologists. The thing that's challenging to us that you would have a real leg up on is as children become young adults and they transfer care from the pediatric center to the adult center. And our pediatric centers are, they're sort of regional, but there are many adult nephrologists. So we have a very challenging time following these young people as they become young adults. And then our healthcare system, we don't have the same degree of data that it seems that you do to follow people. So that's been a challenge. And it seems that you would have a real, combining the publicly available data and a very deep clinical phenotyping, you would be able to really track the long-term outcomes for these children as they become young adults, which is some of the major questions that the families have. Are there analogous cohort studies in diabetes or other childhood chronic disorders?
Actually, in Taiwan, the biggest database is National Health Insurance data. Professor Lee just mentioned that. And another clinical cohort, we have several clinical cohorts. However, the number is always very small in Taiwan. Yeah. Diabetes cohort, I have a diabetes cohort for about 1,200 patients, and they follow up about 20 years now. But
wow.
But the number is still not very sufficient, only about 1,000, yeah.
But if you have good retention, that's really remarkable for that length of time. Good. So I don't see any other questions in the discussion forum. Sure. Shall we close the session?
Yeah. So,
Yeah.
okay. So if the audience have no further question, maybe we have to close this section. And we thank you, Dr. Susan Thruth, for your time and the excellent presentation.
And thank you very much for the invitation. I wish I was there in Taiwan to meet you in person.
Yeah, we look forward to your visit Taiwan.
Okay. All right. Thank you very much.
Thank you. Bye-bye.
Okay. Good night. Thank you.
教授能请教一下，为什么 germ cell tumor 在 rural area 会比较多？有什么解释吗？
我觉得是 pesticide。
是我当然也想到这个。
我觉得是杀虫剂。
是。
像台湾很明显，像 Parkinson，neural 的跟 germ cell 的，这个比较 sensitive。我觉得好像 Parkinson 很明显。
是 Parkinson 在台湾有一篇 paper 被 assign 了，好像快上千次。
也是 rural area。
就是那个叫什么？鱼肺禁用的那个，就是 pesticide 的，然后就
我也觉得，因为我自己
它的 odds ratio 好像30-40，非常高。
应该是农药。
对。那请问，那 rural area 那个定义要怎么定啊？就是
我们现在目前大概最多用那个国北部刘介宇教授，他用了5个 indicator 去，他当时在国务院的时候跟现在的院长杨院长，他们用了5个 indicator 去界定，然后7个310几个降单率分的。7层太多了，我看大陆的研究的都分，我自己都分3层，都位、卫星层次向下。那有些如果探讨稀有疾病的，甚至只有2层向下。那刘介宇教授他是觉得他不能分7层，不要给他病了，因为每个那个病的方式都不太一样。对，他是说，可是你知道分7层太多了，而且有些疾病样本数没有那么多嘛，你分7层根本看不见。所以大概我很少看到7层，3层和2层，就刘介宇教授那个分布。大概是目前是最 update 的，因为台湾城乡其实变化很快。泸州啊，一下子
人口就很多，密密度就很高。
对，他那个应该是2006的分类。那对啊，他自己我听他自己讲，也说好像应该在 revise， 因为有些乡镇市区其实14年以后，它其实可能原来是这一级可能跳到那一级。云林跟嘉义跟彰化，云林跟嘉义跟老化又很严重，它可能更向下。不过大概是2006，最新的。
因为我正在当博士生，然后我在看说，就是用Geographic Information System 来跟台 data 来做串联，然后就碰到到底那个都市跟乡村界定的问题，有好像不是很清楚，因为就那个行政划分其实是另外一回事，跟实际上情况可能差别蛮大的。就有的地方真的，
他那个也是用316的乡镇，
用乡镇去看的是。
因为乡镇是才有那一些可以用来分类的那些什么65岁人口数啦，务农的农业人口数啦，还有那些东西可以用。所以还是用。
那它最小的分别是乡镇嘛，就是用乡镇来看这个是。
中研院统计所，现在他们现在有在弄那个所谓的最小统计区。
是，我有看到那个。
对，但是还没有 release 最小统计区它就是有点像美国那个 neighborhood 邻里。对，那这个东西有一个好处就是说，像他们做医馆喜欢做那个 OGS 在做那个越区就诊。这你不能用。就是说你在就诊这件事情，什么叫越区就诊？你如果住在，比如说好，我们台南，你住在新营，到嘉基去再合理不过。对不对？
是，那个其实比较近啊，比较近啊。只是在一条线画在那边。
可是你用所谓行政区，就是说它是越区，你新营的人应该要来成大，这不合理啊。所以他有考虑这个所谓的，他有用主计处的那个，我看过他们的过程什么台湾人。平均看诊门诊就不会超过18分钟的车程，所以说他有一些做调查，然后把你的生活习惯弄来，然后划所谓的最小统计区，而且他最小统计区是可以重叠的，所以你看着反正很复杂。我一直在看中研院的那个统计所release这个出来，因为他就打破了那个行政区域了。对，那这个对有一些研究来讲，我觉得是。
台北新北市的污染影响很大。对。
对。
我那个呢，要不要再？
请问是？
是一样的，对，坐这个位置，所以那个会像这样。
像个 camera 是吗？
对。
哦 ，camera 就这样子。
对对对。
OK。
然后这边都有。
那个周医师，
周医师，
你们他电话，他问了，那个点位，
昨天还把12寄给我了呢，他到现在还没到。
他还没有给位置。
真的啊？你要告诉我，
真的上面。
我刚刚怎么会这么糊涂呢？不好意思，我真的怎么没到？对呀，他怎么没到？因为他知道时间吗？上个厕所，去上个厕所就没事。
对，是，对。好，谢谢。对，我带他当我的，那个外国讲者机密会给我。
那个 CV 放在这里。对，但是
我还有第3个的 CV。
第3有在这边。
第3个给你。
不对，是这个。对，不好意思。
第3个给我。
第3个是后面这个。
给错了，这边的系统不行。
不好意思。
所以那个陈副院长的，他知道。
OK， 好。
那你跟他讲吧。那我就先坐这边。
好。
他敢打。
对他，我刚刚扣他那个。
那个老外的我说了。
这个是邱医师的 CV。
第一个是你，
第一个是我，对。
好，就他们讲完再聊一个，
一般后面留一段时间就。
我们刚刚 Q&A 跟3个人对谈，
对，
就3个对谈，对，就是你要说你们3个都可以一样对，因为这个蛮好的。到时候可以具体给我们可以。好，第一个是你讲，对，第一个是你讲。
他讲完之后换那个。
陈医师，那你们不要移过来，在镜头比较中间。
OK， 好。
对，好。
我认为那个日本人讲得很好那个日本人
刚才听起来。
对，他讲得蛮好的。对啊，我跟他讲。
然后 Q&A 会是20分钟，就是待会你荧幕上会看得到剩余的时间有倒数。对，讲者台上也会看到剩余的时间倒数30分钟这样子。对，然后座长主要都是坐在台下，然后线上看就是大 个
不用讲这个了，应该不用讲。
不用，这是给您看的。
这个知道就好。
对。
对。
好。
对，那邱信待会上台讲看的是哪一台？可以吗？对。对，这个是同一台。你说你要直接画吗？可以。那你就变成要后面。线上其实看不到，现场看得到。对，很方便翻页这样子。
可以放片。
对。Q&A 就是统一在最后请大家讲。
好。可以了。你多谢，我应该讲爱多谢。我最近真正是有机会再分享，下次吃饭哇，真正这个代志。实在做得很好。你应该留下跟那个日本人再互动一下。我很想，因为这个在台湾都没有做过，我很想写一本中文书，出2篇 paper。我在那边其实有2篇 paper 在那里，就是做这个题目的。对，然后。
日本讲者上线的时候，你有需要先跟他打招呼，就是他的演讲前。
OK， 可以啊。
在介绍他的时候，你可能要跟他打个招呼。
我是想要请那个邱医师来介绍，因为我前面2个都有介绍。
好啊，没问题。
第3个就是他介绍。对，介绍的时候，会后没关系，还好。
顺便跟他打招呼，他是不会有镜头的，那他会出声音。
所以他没有镜头。
目前就是打招呼阶段，那在 Q&A 的时候才会有镜头。
OK， 因为是 Q&A 的时候再打招呼，是吧？
好啊，没问题。
用 Q&A 的时候打招呼。
那你待会介绍完就直接播放他的影片。
对，就这样子。OK， 这样会比较smooth。
好。
就像在演戏一样，就对了。我们在演戏而已。现场观众可能没那么多，但是我们就演一场戏就对了。
你还有经验，我是第1次。你是主办好几次了。
我在想，
有点怪怪的。
没有线上的 Q&A 吗？
有。
但是线上 Q&A 它会秀出来吗？
对，那个，请问一下，线上的
Q&A 有没有线上 Q&A？
会在哪里？
现在有的话，我们会把那个表格就是对，如果线上有的话，我们会贴上去让你看。
你们节目贴
对，我们会贴在这边，我们会自己帮你说看得到的部分。
好
对
，OK，
如果有的话会马上填好。
就我们决定说哪个问题要先问就对了。他们现场的人是没不会出声音，他们就是只有打字，我们就只有直接带动。
好 ，OK， 我知道。就上次我们是这样讲。啊，但这边没有猜谜的时间呢。
这里
不是，10点10分开始的时候。
啊，对。我们是10点10分开始。
对，但我看
这边没有时间，这边没有时间，我们看这里。
我怎么知道要开始？
线上你在前面那台那个荧幕看的时候，会看得到倒数剩余的时间。
不是，我要开始，现在像3分钟
什么时候开始？
哦，好，没有，我
比如我现在先开始可以吗？
我会大概提醒你。
好，当然提醒好，你也提醒好。
因为就30分钟，我就必须要掌握时间了。
谢谢。
日本人就你介绍，前面2个就我。日本那边，那真的万一搞得太久，12点钟一定会离开，因为从12点31的，我就继续。对啊，对啊，但是你们2个现场，时间。
我会努力控制好，我希望可以30分钟就结束。
比吕过的好处，那个日本人25分钟而已。
真的啊？
给他25分钟。
现在你是担心我？
不是担心，是现场有时候时间会比较不好控制。
没有开玩笑。
对啊，20分钟就。
怕 Q&A 出不完。
不会啊，我们就早点结束。假如没有10分钟，其实主要是跟日本人互相想一下问题，完就跟日本人讨论啊。他真的不错。对啊，他的我昨天看了2次他时代，感觉还蛮不错的。他几乎把我的 idea 都呈现。
昨晚跟你要那时代，我没有看。
真的吗？
我没有去拿。
对，我看现场可以。我看昨天我都会看的，不然不看的话就。好，我再搞这张一次 ，OK， 谢谢。OK。
可以看。
Okay. Ladies and gentlemen, good morning. I am Dr. Jin Sun Chen from Kaohsiung Veteran General Hospital. Thank you everyone joining the section. The topic is regarding transition from child to adult care in kidney disease. Today the section will have 3 speakers, 2 speakers from Taiwan. One is from Japan. 2 chairmen in the section. I am Jin Sun Chen from Kaohsiung Veteran General Hospital. And the other, I think, is Dr. Qiu Yixuan, also from Kaohsiung Veteran General Hospital. In the section, so I think I will quickly go through to the section. In the section, first speaker is from Kaohsiung Veteran General Hospital, Professor Yixuan Qiu. And he graduated from School of Medicine, National Yangming University. His current position is Director of the Department of Pediatric Kaohsiung Battery General Hospital, and a clinical professor in Pediatric National Defense Medical College. He also is the current Secretary General Taiwan Society of Pediatric Nephrology. He is also President of Taiwan Society of Development Origin of Health and Disease, and editor of Pediatric and Neonatology. And his specialty is pediatric nephrology and pediatric allergy, immunology, and rheumatology. He won a lot of honor, including the best paper of Taiwan Pediatric Association and the Taiwan Society in Nephrology. Today, his topic is transition from child to adult care in kidney disease pediatric aspect. Let's welcome Professor Cho, please.
Thank you for the moderator introduction. And dear colleague, first of all, welcome everyone to Taiwan, and physically and virtually. Due to the COVID-19, so it's hard to have this meeting. So welcome everyone. And my talk will be transition from the children to the adult care in the kidney disease from the pediatric aspect. So I think as a pediatrician, everyone knows the young patient graduate from the pediatric to adult nephro care now has progressively increased due to the improved the survival in the recent medication, and also the adult renal service are being exposed to increased number of adolescents and the young adult patients, because this patient may be transition from pediatric care or may be presented directly to the adult service. And there are substantial risk of non-adherence at the time of transfer from the pediatric to the adult care. And among the cohort of the patient aged less than 25 years old. And the most frequent the etiology of the adolescent onset CKD stage 5 is a glomerular disease, but in the younger children, the major abnormality is congenital defect. We say CACUD, like a renal dysplasia, like a VU reflux, and also there's a inheritary disease also. And in the adult nephrologist, may be less familiar with these later conditions. So the difficulty of dealing with the adolescent patient who have chronic illness due to the maybe physical, psychological, and the sexual change about their developmental. And this makes the management and the transition issue for the patient, for the family, and for staff is a challenging issue. So the definition of transition, very early is 1993. There's a position paper from Society of Adolescent Medicine. And this definition says a process that involves purposeful, planned effort to prepare the pediatric patient to move from the caregiver-directed care to the disease self-management, and in the adult unit. And moreover, the ISN and the IPNA, there has a consensus about the pediatric patient with the CKD in the 2011. There's in this statement, it is indicated that the transfer from the pediatric to the adult nephrology services should occur only after preparation and assessment have been performed. And I think all we know, the transfer from the pediatric to adult maybe have many aspects, but the transfer should take place when the patient has completed school education, have attained sufficient social and psychological development, and are stable in terms of symptom and the psychological status. So it is recommended to create also an organization to consist of physician, nurse, psychological specialist, social worker, and other relevant persons. And they are all well trained in transition program to support the transition. and to the implementation of the transition program through the collaboration with the adult healthcare unit. And in Taiwan, this topic, or maybe this issue, is quite new in Taiwan, because the transition program, I think, is maybe we need to establish in Taiwan. So the support for the transition, from here we can see that the young person, they maybe need the transition plan, and maybe the family support is very important, and the peer group support. And in the pediatric unit, we have a transition companion and other user worker. And adult unit, there is maybe more for young adult and also to the adult clinic. So this should work together. And this example of the competence of expect for young adult transfer to an adult unit. They have many questions. So how to deal with this? Maybe the patient will say, I under my condition and can describe it to others. You know, almost every patient that depend on their families. So when they grow up, they can deal with themselves. And the patient say, I know my medication and what they are for, and I can make decision for myself about my treatment. And also, he need to learn the adult clinical arrangement. We will be review him in the clinics, and she or he should need to know how to make the appointment by himself, and also the transportation to hospital, and also if I have any problem, can call the medical emergency by himself. All about these things he should know how to do. And also about the diary, about the sexual health matter, and others like the alcohol, smoking, drug issue. I think this we will be countered in the future. So transition from the pediatric to adult care, Japanese has also have a new guideline in the 2018, and they just have 3 key points here. One, when we do the transition, we need to ensure that the transfer from pediatric to the adult care does not cause disruption to advanced and high quality medical cares. And the second one we need to know is transfer patient from the pediatric to adult care. We should especially achieve about the sufficient psychological and the social development support. And we need the relevant education for all our small patients when they grow up. And also we avoid the transfer as far as possible if the patient's symptom or psychological status is unstable. So I think this is every pediatric nephrologist, you know this condition. It means the patient and also the family all stick to the pediatric doctor. So the relationship is very close. So the transition maybe is a very important thing for them to transfer to a new doctor, a new clinic. And the third, the transfer from pediatric to adult care should occur only after preparation and the assessment have been made. So it is important to implement transition program. So this is why the Japanese, they have so-called the transition program there. I think in Taiwan today is a special situation, yeah. And here we have pediatric nephrology doctor here, and also we have adult nephrology doctor here. So later, Dr. Zhou will have a lecture about from the adult view. So how to collaborate, I think, is very important, especially in the future for the CKD or for the kidney disease children in Taiwan. I think today is a very important time. So this is from the pediatric. There's a 2018. There's a transition about the timeline for the transition of the pediatric disease to the adult. And in this article, they discuss many diseases, not only for the renal disease, but there's a very good point. One is the early preparation. In this article, they have a six core idea, 6 core elements into the pediatric practice. And they start earlier as 12 years old. So we can see from very left side, then when the age 12 to 14, we discuss transition policy to the family and to the patient, and then they track the progress gradually. So the transition check-in and the monitoring, then assess skill. Is the patient ready and the family ready, and also our physician and our medical co-worker should be ready, and then develop the special program. Then to the age of 18 to 21, they transfer to adult-centered care and the integration into adult practice. Then from the 18 years old to 26, they confirm the transfer completion and the consumer, and then elicit the consumer feedback, and then can adjust our program. So in detail, the transfer program can just see in the pediatric and adults have different conditions. Like we say in the number one, the transition or the care policy. We create and discuss with youth and the family, and the adult nephrologists, they create and discuss with the young adult and the guardian if needed. Then we check in and monitor how they progress, and then when the transition readiness for orientation to the adult practice. So we conduct the transition readiness assessment. Then gradually transition to the adult. So I do not go through one by one. So this process maybe take long time to finish. As we know, in my daily practice, I just when the patient is 18 years old, I just tell them or tell her, so, oh, you are 18 years old already. Would you like to transfer to a adult nephrologist? So we sure need many such program to do this work, because when you say, oh, you are more than 18 or more than 20, they always ask, can I stay on your clinic? So that's the real condition. Yeah. So children is different from adult. So from today's talk, so we have in our group, we have considered what's the difference and what can we do. So, or what should we do? So from the etiology or from the beginning, what is the cause of the CKD or the kidney disease in the children? I think it's quite different from the adults. So we have a Taiwan Pediatric Renal Collaborative Study, and in 2016 we have published a serious paper, and this the number is 971, and we can see now about the primary cause of the CKD in children in Taiwan. The glomerular is 48.9%, and the non-glomerular majorly is the Kakut, is 51.1%. So this is quite different from adult patient with a CKD, because as we know, the adult CKD majorly is DM nephropathy, and then a glomerular nephritis is second, and maybe hypertension in the third. And the second is this is distribution of our CKD patient staging. So most of them is below stage 3. And this is another paper we just to see the disease progression, factor of the disease progression. And we can see in our group, we can see the disease progression, the risk factor of the disease progression will be they associated with congenital heart, and in the right side, the nephritis group, the autoimmune disease is quite different. And also hyperuricemia and hypertension, they are all the risk factor for our CKD patient to have progression. And also in the treatment and the complication, there's many facets of our pediatric patient with the CKD, and we can see A, B, C, D, E, F, G, H. I think the most important one is the growth and the mental health, because every children has only one chance for growth. So about the growth hormone, about the diet, and about the anemia control, they all always affect the growth. And also the mentality, because children still under education, and they also need to maturation. So this point is quite different from at that point. So this is one of our patients. Okay, he say I'm 11, but I'm only 113 centimeter high only. It should be 137. So this is our pediatric nephrologist always have minute condition. And others is a health mental. So I'm not deeply into this course. And so we have conducted a study about the transition, and we think about, because in the daily practice we have noted that now we use the eGFR as our method to estimate the glomerular filtration, and we have used a different formulation for the children and for the adult. In the children less than 16 years old, we use the modified Schwartz formula. But when they grow up to 18 years old, then we use the MDRD formula. And in the clinical, we have seen some discrepancy, some difference over there. So we try to use our population-based longitudinal health insurance database, we say LHID, to explore the prevalence of different etiology of pediatric CKD, and also use our big data of our Kaohsiung Veteran General Hospital big data bank. So this is the formulation we use. Okay, we see the next one. One is Kaohsiung Veteran General Hospital big data bank, and one is LHID. So the first of all, we see from the LHID, this is from our national insurance data, and we tried 3,066 pediatric CKD patients, and our criteria is the what is transferred, the definition, or we use if the patient changes their medical claim from pediatric department and then to the adult internal medicine department, family medicine, or the GU or nephrology department. After 18 years old, we define they have good transfer. If not, or they are still stay in the pediatric department, we say, it is not transfer. And if loss follow up or maybe improve, we say loss. Okay. So finally, from here we also see the CACU is the main cause of pediatric CKD. So the same as our previous study. And about the transfer, the higher transfer is the GM patient is 63%. And we can see the first column, the transition in CACUT, we may see transition in keep in the pediatric department is 7%, and the transfer to adult is 21%, and the cure loss follow-up is 72%. And also in GM patient, at the similar percentage. So we have discussed about this, why the cure loss to follow-up is so many patients. So maybe it's due to this patient, maybe they did not go to the adult nephrology section. So they just maybe just lost follow-up or didn't have many good care. So this is how we see the transfer rate in our study. And this is from Kaohsiung Veteran General Hospital big data bank. And we want to know the two equation for EGFR is the same or the different is will cause any discrepancy in this patient when they transfer from the young adult to the adult. So our criteria is the adolescents and the young adults, we say AYA, age 15 to 21 years old, and we recruit at least 3 tests of serum creatinine individually between the age of 15 to 17 years old. And then the second one is 18 and 20 years old. And we compare the creatinine level. And the result we surprisingly to know, and the MDRD EGFR formula, they has a higher than modified Schwartz EGFR with the discrepancy of 27 to 35 cc per minute per 1.73 meter square. So the upper figure is for the all patients, and the second figure is for the female, and the last one is for the male. Now we can see that the male AYA had a higher discrepancy than female AYA, and also we found that when the patient with the BMI larger than 25 is the more obese the patient. This is a dependent factor for higher EGFR discrepancy, and the R ratio is high, is 14. When the MDRD and Schwartz ratio 1.5. So what's the meaning of the ratio of 1.5? We can see when the R ratio of EGFR ratio to when the EGFR, the MDRD, and divided by Schwartz, the ratio is more than 1.5. The R ratio is very, very high. What's the meaning? If an adolescent, they have an EGFR of 60, and the next day he go to adult clinic, and then the same creatinine, but his EGFR suddenly higher to 90. So maybe from the stage 2 turn to stage 1, maybe stage 3 turn to stage 1. So this is a big discrepancy. So, but our study is without a gold standard, the GFR in our study. But this discrepancy, I think, is very, very important for our study. So maybe due to MDRD formulation overestimate, and maybe also the Schwartz formula underestimate of the EGFR. But because our case number is limited, so maybe we need in the future maybe have more data to collect to see the real discrepancy between our EGFR usage. And also in our study, we highlighted the overweight is a major risk factor for the higher EGFR discrepancy. And this may be, as we discussed, maybe the male sex have higher EGFR discrepancy than the female, maybe related to the nonlinear increase in the pubertal muscle mass during adolescence. And in our study, we also see the Kaku predominant in our CKD patient, followed by the GN. And the final one is that our GN patient has higher transfer ratio than the Kakut. And maybe this reason, maybe adult nephrologists are more familiar with GN than the Kakut patients. So it's more difficult for our pediatrician to transfer Kakut patient to adult nephrologist. So finally, is the take-home message. During my talk, I think the transition from pediatric to the adult renal service is an individualized process. And then this provides the young person with a proper self-management skill and access support structure. And the second is as young people are in the transition from the 14 to 24 years old, it is vital that there is a good communication between the pediatric and the adult nephrology doctors, and also the service, especially at the point of transfer. I think these 2 points is very important in Taiwan for all our colleagues to think about this condition. And the third is the support for this age group should be developed on both pediatric and adult focus side. The consensus statements are necessary to ensure a successful health care transition process, especially the children are in development. So I hope in the future we can collaborate and we have a transition program for all our pediatrics children and when they grow up. And thank you for your attention.
Okay, we thanks for Professor Cho's excellent presentation. Because of our live Q&A will be after our presentation in the section. So we will move to the next topic. As everybody know, after pediatric aspect, next we will move to adult aspect. So I will introduce the next speaker to everyone. Next speaker is Dr. Julin Zhou. Julin Zhou, he graduated from School of Medicine at National Defense Medical Center, Taipei, Taiwan. He got his PhD degree from Institute of Medical Science, Tzu Chi University, Hualien, Taiwan. His current position is Director of a Division of Nephrology, Department of Internal Medicine, Xinguomin Hospital, Taipei Medical University, Taoyuan City in Taiwan. He also is Assistant Professor of the Department of Internal Medicine, Taipei Medical University. Today, his topic is transition from child to adult care in kidney disease from adult aspect. Now, welcome Dr. Zhou.
Okay.
Please.
Okay. Good day. Thank you for the invitation by Professor Cho and Professor Chen. Today I'm here to talk about one topic that transition from adolescent to adult care in kidney disease from adult aspect. First of all, I divide my presentation into 3 parts, including background issues regarding CKD at the transition from adolescent to adult care, and finally take-home message. Firstly, adolescents are between childrenhood and adulthood has posed a conundrum. They could face some problems like biological growth and major social role transitions. And the aging range of the new adolescents is between 10 to 24 years, which corresponding to adolescent growth and popular understanding. And in this table, we can as we know, aging is associated with significant changes in structure and function of kidney. Regarding this of aging-related comorbidities, in the healthy aging, we can see in the healthy aging, they may be can encounter the kidney problem like nephrosclerosis and decreased nephron numbers with aging. And if this patient with comorbidity or CKD, they can maybe have easy to easy have the CKD development. And we can see structural and functional finding in the CKD with health agent. In microscope structural change, we can see arteriosclerosis, tubular atrophy, and decrease in naval lumbar. In microstructural changes, we can find decrease in cortical bone and an increase in sister lumbar. In the functional changes, we can see decrease in total kidney GFR. But in the health agent kidney, stable growth, glomerular volume, and stable sickle naval GFR is noticed. And we can see total kidney GFR change from children and adult. From 3 years old to we can adult 20 years old. The eGFR remains steady, and we can compare between single naval GFR and total eGFR changes from adolescents to older adult. In single naval GFR, since 18 to 16, single naval GFR remains stable, but since 14 years old, total GFR get decreased. And in the age 16 to 5 years old, we can find if they have a higher single naval GFR, maybe indicating they have a central risk factor for kidney disease and central kidney biopsy findings. And the creatinine levels is affected by growth, maybe making a confounder in the assessment of kidney function from creatinine alone. There are a variety of tests of kidney functions. We can approach kidney function by urinary clearance with heterogeneous markers and urinary clearance of creatinine and plasma clearance. But there are varieties of kidney function tests. They have pros and cons, but we use urinary clearance as the golden standard to assess renal function. So in this table, we can see these patients have kidney disease. The range age was between 1 to 12 years old. We use urinary clearance as the standard. These equations marked by blue light are similar to urinary clearance. So we can use these equations to assess eGFR. I think it's very useful. In this study, the author make a comparison of the Cochrane, Gott-Schwarz, and MDRD formula in the children and young adults. In the A is represent all children, B is lung single kidney and lung transplanted. C represent single kidney, and D is transplanted kidney. So let's see. Whatever the groups, no difference between indolent kidneys and cochlear gut. But we can find Schwartz and MDRC formula overestimated indolent kidneys by at least 20%. And in the doubt, we use indolent kidneys as a standard. We can see cochlear gut and MDRD formula were not a significant difference between these equations. But we can see another problem. Creatinine correlation overestimate the indolent correlation cochlear gut and MDRD by at least 25 years, 5%. Yeah. And adolescents and young adult kidney CKD patients face a complex challenge. So they have multifarious comorbidities, and their 10 years survival range from 17 to 85%. The mortality rate is still 30 times higher than their healthy peers. So in the etiology of CKD in children, we can find structural abnormalities are predominant in children. And in the glomerular disease, steroid-resistant nephrotic syndrome is the first, and we can see the second is the glomerular nephritis. But in the Japan and Australia and New Zealand, they report glomerular nephritis to be the most common cause of ESRD. In Taiwan data, we can see these figures were similar between abnormalization and glomerular disease. In the glomerular disease category, lupus nephritis is the common causes of CKD in Taiwan in children. And with aging, structural abnormalization got a decrease, but in the more than 12 years old, glomerular disease get an increase with aging. There are clinical complications of CKD. So we can see in the children, they face more problems like gross nutrition, endocrine problem, and bone disease. In the adult, they always face cardiovascular and bone disease. And then more challenge from CKD adolescence. Adolescence is a critical time for growth and psychosocial development. they need to face CKD mineral and bone disorder with anemia and endocrine imbalance and in malnutrition. So the poor family support and socio-economic status could cause the poor long-term outcomes and decrease quality of life. In this project, the authors do the follow-up questionnaire on pediatric renal care, including 14 for European countries. The authors conclude that transition programs from pediatric to adult renal care is listed in 52% of countries. So we need to further improve pediatric kidney care by harmonizing the diversity of renal care for transition program. And if this pediatric patient get the chance of the transition, they always agreed by 16%. So new pathways for transition and integration to adult services have been developed, and supportive transfer to adult services is essential. So as we know, healthcare transition maybe have a cooperation between adolescents, parents, and health professionals. So recently report there are many system review to highlight this topic. So the timing of the transition is highlighted by clinical practice. So what is the timing of transition? And if we have to do transition, we need to prepare some strategies like wear planning and do clinical appointments and decide timing of transfer, and care about pediatric attitudes and feelings. So in Japan, this is the Japan data. So we can see the timing of transition is at age 20 to 24. So they always proposed by doctors. And so we conclude what is the timing of transfer. In this system review, the authors suggest that young people with diabetic and CKD are recommended 15 to 24 years of age for transition. And in conclusion, the authors suggest age 18 was the appropriate time of transfer. More models of transition can improve transition outcomes and patient satisfaction. So, how to improve the transition process? We can do some strategy like preparing information on the adult health services, give patient peer support from those who has been successful transfer to adult care. and having the contact details of health professionals in the doctor health services. And finally, arranging a tour of doctor health services. So, in conclusion, adolescence is a conundrum. So, these patients should face biological growth and major social law transitions. And aging is associated with significant changes in structure and function of kidney. Regarding this of aging-related comorbidities, and the creatinine levels are affected by growth, so making growth confounder in the assessment of kidney function from creatinine alone. Adolescence is a critical time for growth and psychosocial development in patients with CKD or ESRD. And the poor family support and socio-economic status will cause the poor long-term outcomes and decrease quality of life in this patient. And finally, appropriate models and plans of transition can improve transition outcomes and patient satisfaction. Thank you.
Thanks for our first two speakers. In the session, we are a little bit ahead of our schedule, or around 10 minutes. But that's okay because we have more time to discussion. Okay, in the Q&A. Okay, we move to the last speaker. Please, Professor Cho, introduce the last speaker. Okay.
Okay. Next we welcome Professor Yukata Harita. And I have a short introduction for the Dr. Yukata. He has had education in the 1993 to 1999 at the Faculty of Medicine in the Tokyo University. And then he graduated School of Medicine in the University of Tokyo from 2003 to 2007. And then his teaching activity, he is the project assistant professor in the Department of Cellular Proteomics, Institute of Medical Science at the University of Tokyo from the 2007 to 2009. And then he moved to the Yokohama City University as the project assistant professor at the Department of Cellular Biology and the Graduate School of Medicine in Yokohama. And from 2011, he is a lecturer of the Department of Pediatrics, Graduate School of Medicine in the University of Tokyo. And he be an associate professor now from 2018. And today's talk for him is the chronic kidney disease from a life stage perspective. So let's welcome Professor Yukata Harita.
Thank you very much for giving me this opportunity to talk in this session today. The aim of my presentation is to provide a view of CKD in both children and adults from perspective of life stages. As I am about to tell you, CKD has various unique characteristics in different countries and regions. As I am working in Japan, the issues stated here may not be immediately or directly applied to your country or regions, but I would be happy if I can be of some help by sharing our challenges with you. First of all, I'd like to review the current status of ESRD in various countries. This figure from 2013 Lancet paper demonstrates prevalences of ESRD in each country or region. Its prevalence in Japan is second only to Taiwan, and the third highest country is United States. Portugal, Belgium, and South Korea are the next on the list. While the frequency of ESRD varies, the causative diseases of CKD differ significantly by country or region. Causes of CKD in Asian countries was extracted from this paper. In Japan, diabetic nephropathy, shown in blue, is the most common cause, but more than 60% are by other etiologies, including chronic glomerulonephritis and hypertensive nephropathy. We can see that other countries or regions have its own characteristics, such as a low rate of diabetic nephropathy and a high rate of glomerulonephritis. The prevalence of CKD is about 9% worldwide, which is known to be somewhat higher in Japan. Recent report demonstrated that CKD has increased by 40% in the last 20 to 30 years. On global scale, targeting CKD will be an important consideration for reaching sustained developmental goals. And it is widely recognized that CKD should be managed in its early stages by general internists as well as pediatricians. In my talk, I would like to go one step further and look at CKD in the life stages. This figure shows the life stages and processes of CKD. In early stages in life, renal function tends to be affected largely by congenital or genetic factors, but gradually various acquired effects are added. A decrease in the number of nephrons, which is caused by a variety of influences, can affect kidney function throughout life, and its effect gradually become more significant in later life stages. Today, I want to talk about several findings on the development of CKD in life stages. The topics will cover fetal life, childhood diseases, and adult life. First, I will talk about factors before birth affecting development of CKD. Regarding this topic, this famous study published in 1986 demonstrated the relationship between prenatal environment and adult health. The figures shows mortality for ischemic heart disease in 1968 to 78 in y-axis and neonatal or perinatal mortality rates in 1921 to 25 in x-axis. The data of x-axis is about 50 years before the data of the y-axis was collected. Each dot represents one of the over 200 regions of the United Kingdom. As you can see, the mortality of babies correlates with the mortality rate for heart disease decades later, suggesting the possibility that living environment in fetal and infant period is related to the onset of ischemic heart disease in adults. This hypothesis is now called Developmental Origins of Health and Disease, DOHAD. Accumulating evidences revealed that the fetal environment is also associated with various diseases such as hypertension, cerebrovascular disease, or diabetes. For example, low birth weight is associated with the development of hypertension. The impact of preterm birth or low birth weight on blood pressure and odds ratios have been calculated. Initially, CKD was not discussed in the context of DOHAD. A little later, studies in nephrology confirmed that low birth weight is correlated with kidney diseases. It is found to increase the odds ratio of CKD, ESRD, and albuminuria by about 1.5 to 1.8. Therefore, CKD is now acknowledged as one of the DOHAD disease. Maybe you may wonder why I am talking about low birth weight. It is because low birth weight is a big problem for us in Japan. The upper figure shows the percentage of low birth weight infant in OECD countries. The rate of low birth weight infant in Japan is just under 10%, which is one of the highest among OECD countries. When did this rate start to increase? Lower figure shows that the ratio in Japan, shown in red, was about 5 to 6% in 1980s. It increased since the 1990s, and now 20 years have passed since the rapid increase. The results of increased low birth weight is now apparent in a variety of indicators in Japanese populations. The figure on the left shows the percentage of low birth weight infant in Japanese men by year on the x-axis and the average height on the y-axis. These two numbers correlate nicely, and average height decreased from 1980s as the percentage of low birth weight increases. How about its effect on renal function? The figure on the upper right shows the ratio of low birth weight and mild renal dysfunction in physical examination in one Japanese school. We can see that low birth weight rate and renal dysfunction increase in these periods. The authors demonstrated that low birth weight infant is more likely to result in decreased kidney function. And a larger pediatric CKD cohort study in Japan has also shown that low birth weight has increased the rate of CKD. What causes increased low birth weight in Japan? Maternal weight gain in reproductive age women appeared to be the major factor. Internet is full of misinformation, such as how to lose weight during pregnancy, or why do I need to lose weight during pregnancy? Skinny body shape becomes more popular, and misinformation is becoming more and more prevalent. This figure on the right top shows an international comparison of BMI for men in x-axis and women in y-axis. Japan is here, and you can see that the BMI of Japanese women is very, very low, even compared to that of Japanese men. Trends in BMI for men and women are shown here, and the trend of decreasing BMI is pronounced in young women since around 1980s. Japanese women are not getting the nutrition they need, and this trend is getting worse. Moreover, although the causative link has not been clarified, advanced maternal age pregnancy is also thought to be associated with low birth weight infant. The left figure showed the mean first marriage age of women in blue and mean age of mother of first birth in orange. As shown here, the age of childbearing mother has significantly increased in these 40 years in Japan, and the average age of the mother at first delivery is now over 30 years old. This change is tightly associated with increased rate of assisted reproductive technologies pregnancy, which has various potential complications. And another point is advances in neonatal medicine. The right figure shows low birth weight rate in x-axis and infant mortality in y-axis. Infant mortality rate is still low in Japan despite high low birth weight rate. These factors underlie the increasing low birth weight infant in Japan. Physicians as well as pediatricians who treat young patients with CKD need to acknowledge the prenatal environment as an important factor for CKD. Second topic is on the history of childhood kidney disease. An Israeli group has made great progresses in this area of research. This is nationwide population-based historical cohort study of over 1.5 million Israeli adolescents who were examined before compulsory military service. The authors showed that a history of clinically evident kidney disease in childhood, such as Kakut, pyelonephritis, glomerular disease, are associated with a significantly increased risk of ESRD, even if renal function was apparently normal in adolescence. Subsequent studies have further examined pyelonephritis in detail. These figures show years of follow-up and survival of people with or without pyelonephritis. History of pyelonephritis, particularly when associated with kidney scarring or reduced baseline kidney function, significantly increased risk of ESRD. Therefore, a history of childhood kidney disease, even if cured later, can underlie development of adult CKD. The third part is on the congenital or genetic factors in adult CKD. As we all know, congenital or genetic factors are the major causes of ESRD in children. In a survey of pediatric ESRD in Japan, 40% of cases were Kakut and over 10% by genetic nephropathy. This review below showed that the structural factors are significant in CKD, especially in young children. So what about CKD in adults? Diabetic nephropathy accounts for 40% of adult ESRD, and 1 in 4 cases are chronic nephritis. So aren't there many congenital factors? How much congenital factors affect adult ESRD? German research group analyzed the age of initiation of renal replacement therapy in Kakut and other diseases. They found that kidney failure in Kakut is of course more common in childhood, but many people with Kakut develop kidney failure even in adulthood. Congenital factors are more common than previously thought in cases of CKD and ESRD in adults. Regarding the genetic background, next-generation sequences NGS has now widely used in clinical settings. The likelihood that NGS identify the causes of the disease differs by diseases, but in pediatric CKD, the cause is identified in up to 20% of total cases. Recent large-scale study analyzing adults with CKD demonstrated that genetic factors were found in about 10% of adult CKD patients. The most common causative genes are PKD1 or 2 and COL4, 3, 4, or 5. These results suggest that congenital or genetic factors underlies adult CKD, and these factors may not always be recognized during childhood. As we have seen so far, genetic, prenatal, or childhood factors can have a significant impact on CKD development over a long lifespan. Then what can we do to treat CKD as pediatricians or nephrologists? Early detection, intervention, and transitions to adult care is the key for CKD care. When it comes to early detection, urine testing systems have been promoted since 1960s for 3-year-old children, 1970s for school children, and since 1980s for adults in Japan. The upper right panel shows the trend of underlying disease of ESRD in Japan. Chronic nephritis have markedly decreased and DKD has increased in these 40 years. The lower panels show the relationship between patients' age of maintenance renal replacement therapy in x-axis and the incidence of chronic glomerulonephritis and DKD in y-axis. Chronic nephritis have decreased from the 1980s to 2000 in the younger age groups, but increased in the older patients. On the other hand, DKD has increased in all age groups in this time period. The decrease of chronic glomerulonephritis in young Japanese in this period is considered to reflect early detection of nephritis through school urinalysis from 1970s. As we all know, glomerular diseases such as glomerulonephritis, nephrotic syndrome are relatively easy to identify by urinalysis. On the other hand, structural abnormalities, which are more frequent as the cause of CKD and ESRD in children, are more difficult to detect by urinalysis. This is because these diseases do not cause proteinuria or hematuria in the first place, and they also produce and dilute urine due to poor concentration capacity. Let me share with you some of our research. We aim to establish a urine biomarker that sensitively captures changes in renal function for early detection of pediatric CKD. For this purpose, we thought it was necessary to eliminate the effect of dilution. Therefore, we focused on urinary extracellular vesicles, UEVs, which can be purified from urine, avoiding the effect of dilution. Extracellular vesicles are formed by endocytotic pathway or budding and contain molecular information such as proteins and nucleic acids inside the cells. Their membranes contain tetraspanning molecules and lipids such as phosphatidylserine, which serves as specific markers for these vesicles. We established purification method or extracellular vesicles from urine and compared these from healthy children and those from children with hypoplastic kidneys as a simple model of decreased nephron number. Comparing the proteomes of urinary EVs, we found a group of molecules that are altered in normal controls or renal hypoplasia. Using the expression levels of these molecules, we were able to distinguish these two groups. And based on these findings, we examined urine samples from 30 pediatric CKD patients. Here is a quantitative proteomic heat map of urinary EVs from each patient. Green or black box above the heat map indicate the patient has advanced CKD, stage 3 or 4. This result demonstrated that expression levels of these molecules in UEVs efficiently divide patients in two groups, one with decreased renal function and the other with normal GFR. In addition, we have developed a system to quantify several molecules by enzyme-linked immunosolvent assay, or ELISA, to make it easier to measure them in clinical settings. This ROC curve shows 2 or 3 molecules can be used to diagnose a decrease in eGFR. This result suggests the possibility of urine biomarker to detect decreased renal function. We hope that this study will lead to the development of a new urine-based screening method for early detection of pediatric CKD. Once early detection is achieved, the next step will be early intervention. The famous ESCAPE study showed that strict blood pressure control of childhood CKD caused by various diseases inhibited its progression to renal failure. On the other hand, recent studies suggest that hypertension remains undertreated and under-recognized in children with CKD. Therefore, it is important to continue appropriate care, especially for high-risk populations, which include low birth weight infant, especially extremely low birth weight infant, patients with neonatal or other history of AKI, CACUD, hypertension, or other pediatric onset renal disease. In the neonatal field, there are various proposals on how to follow up neonatal AKI and low birth weight infant in particular. The last but most important point is transition of pediatric CKD patients to adult care. The patient, pediatrician, and adult nephrologists need to work together in a coordinated effort. There have been many attempts to make successful transition. For example, gut transition provides tools and resources for both patients and medical professionals. In Japan, a medical guide on transition for adolescent and young adult patients has been developed in cooperation with Japanese Society of Nephrology and the Japanese Society of Pediatric Nephrology. This guidebook includes the purpose of transition program, and clinical questions on diagnosis and management of young CKD patients. There are a number of problems that arise in regard to transition from care by pediatricians to medical treatment by adult nephrology. For example, in the case of nephrotic syndrome, which of the following is different between guidelines for childhood nephrotic syndrome and adult nephrotic syndrome? Is there any difference in definition of NS, remission, relapse, refractory NS, or initial treatment? The correct answer, at least in Japan, is all of them. Everything from the definition of nephrotic syndrome to initial treatment are different between children and adults. This can be an obstacle for adult clinicians to continuously treat a single patient in adolescent. Because of this background, the assistant guide was developed to fill treatment gaps and to provide a tool to support transition care of patients with IgA nephropathy and MCNS to diseases with large number of young patients. It provides practical Q&A information that should be shared among adult practitioners, family physicians, and pediatricians. I talked about the importance of factors that arise before or after birth and in childhood stages which underlie risks of CKD throughout life. Pediatricians and internists need to work together to provide consistent care by sharing the similarities and differences of diseases in each life stage. Act early to prevent it was the theme of World Kidney Day 2016. I hope that this talk will encourage both adult and pediatric nephrologists, as well as those involved in nephrology in various countries, to work together. Thank you very much for your attention.
Okay, we thank you for the Professor Yukata Harita's excellent lecture. So now we move to the Q&A section. Hi.
Hi, Professor Harita. Hi, nice to meet
Thank
you.
you. Nice to
I'm
meet
Dr.
you.
Chen.
And Dr.
Nice
Cho.
to meet you.
I know you do a lot of scene, excellent scene, according to Professor Nagaku, because I know Nagaku very well. Okay. Okay. First, I think I would like to have Professor Nagaku join the live Q&A. Okay, but second, we still have around around 30 minutes to do the live Q&As. I know according to our conference faculty, we have online participants around 20, and the on-site around 20, around 20. So we would like to invite online, either online or on-site participant to raise your question. Particular for online participant, do you have any question? Please raise your question by your mail. The mail. I will ask all speakers represent your question. Okay. So we invite our audience. Do you have any question to ask our speakers?
I would like to ask Professor Chu. I heard your wonderful presentation according to applying the MDRT formula or the pairwise formula on the young adolescent and young adults. And I think MDRT formula is basically originates from the individuals 30 years or more. So to apply this formula on young adults and adolescents, we must be very cautious. And there was a paper published in the JSON on 2012 that has a delicate study that they checked 750 individuals, young adults and adolescents ranging from 10 years old to 26 years old, and they measured the GFR by annual clearance. So they then compare between the estimated GFR formulations such as pairwise formula and MDRT formula. And their conclusion is that the pairwise formula is much better than the MDRT formula from age 10 to 21 years old. And I would like to ask Professor Chu, based on your data in Taiwanese adolescents and young adults, what is your suggestions for using the pairwise formula in favoring of the MDRT formula? Do you have a conclusion to how old, up to how many years old we should use the pairwise formula that is better than the MDRT formula? Thank you.
Okay, thank you for the Dr. Zhuang's good question. I think this question is very important one. As we know, the MDRT formula, when it development is use adult with the CKD, the average EGFR just around 40, and to develop this formula, and then because when aging will have the muscle wasting, so they do some age adjustment for the elder age for this. So we can see from the formula there's age, and then there's have this point and this part over there. So if we use the MDRT in our pediatric group, especially the small one, we should be careful because the muscle mass is different. So in our daily practice, we have found if we use MDRT in the children less than 16 years old, there may be 200, 300, 400 EGFR over there. So the MDRT when the design is for the adults, and also so we use it for bigger than 20 years old. And about the Schwartz formula, the Schwartz formula originally paper is from 1 year old to the 16 years old. So there's a gap over there. I mean the 16 to 20 or maybe 16 to 18, this age group now is no very good study over there. But as we know, the epi equation, that one is more suitable for this young adult age. So this, I think we need more study for this one. But in our study from the LHI from the national insurance data and from the Kaohsiung Veteran Hospital data. Because we don't have a golden standard for this. I mean, like the in-union study for the golden standard, and to see the EGFR is what is the discrimination over there. So if we want to know the answer for the Dr. Zhuang, maybe we need to initiate one, like the population-based study for the in-union, and to see the adolescence difference for this one. So now we can use the most problem, I think, is the EPI equation is maybe more better for this one. And the other is I know is a cystinuria. There's another formula. I'm not so familiar with this one. And this one, some papers discuss maybe it's a good one for estimate about during the young adult. So that's what we know about the equation used for the children. So this is also a point of future study, because we don't have an answer right now for this important point.
I think maybe Professor Harita, I would like to pass the question to you. I think I know in Japan accumulated a lot of experience about the question. Do you have any comment about the question?
Yeah, the professor nicely showed that it is important to note that the way EGFR is calculated makes big difference. And we Japanese use a formula that is based on our body shape, using height or sex or age. And have you considered that using the Japanese formula? Because as for body shape between Taiwanese or Japanese, I don't think there's much difference.
I'm not a Chen. I know in Japan develop a lot of formula for estimate GFR, maybe based on creatinine or based on cystatin C. Yes, I know, but I think most of the time you use creatinine, not cystatin C in your clinical.
Both either creatinine or cystatin, or both creatinine and cystatin C.
Okay. So you use both in your clinical practice?
No, that the usual practice, we only measure creatinine, but it's sometimes cystatin C, and there is also a formula using cystatin C.
Okay, I got it. So, Professor Harita, I think be honest, I may enjoy your excellent talk. I have one question for you. Your basic study about a biomarker for low phone number. According to your presentation, your study group is based on renal hypoplasia. But renal hypoplasia, that means a size, not a number. So do you have any comment about size and the number in our kidney?
Yeah, and as you pointed out, that we haven't analyzed the relationship between the urinary result and the nephron number itself, calculating by the pathology, because those patients usually does not have renal biopsy, because those Kakut disease are not diagnosed by pathology. So we don't know the relationship between the result and the nephron number itself. But as a model of nephron loss, decreased nephron number, we used renal hypoplasia as the most extreme model of decreased nephron number.
Yes, I got your idea. But I'm a adult nephrologist. But in my daily practice, I think I found some patient, their kidney size a little bit small than general population, but his kidney function, I think is good. So size is not maybe not good correlated to a number. So that's my point about your study.
Okay, thank you very much. And yeah, our weak point also is the kidney function is compensated for a long time, long period in early stage of CKD. So as you mentioned that if the nephron number is decreased, but EGFR can be maintained in early stage. So our study also ignored the early changes of in kidney because the EGFR of the patients are maintained. So it's another challenge to identify the biomarkers for those early stage CKD, even they are not, even they are in the normal GFR, but decreased nephron number. But that is our next challenge, I think.
Okay, thanks. Any?
Thank you for the excellent section. I have a question. Is that just you speak about the GFR calculation equation different in different age group. So when we are talking about the transition care, if the patient is in the pediatrician care, then maybe he is appropriate to use the Schwartz equation to calculate their eGFR. However, when they are transferred to the adult nephrologist, what is the time point to change to the CKD-AP equation or to the MDRD? Is the younger than 16 years old, then use the Schwartz, and then 16 to 18 or 20 use the CKD-AP, and the older than 20 years old, then use the MDRD equation? This is the first question. And the second question for me is that because right now the transition rate is not very good, especially I heard from Dr. Cho saying that the transition rate in Taiwan now is about 30 to 40% only. So maybe we have to educate the parents and also the physicians, nephrologists. But I think in the beginning, because there is a lot of variety in the child CKD group. So what do you think? Who is the most needed to be transferred? Who is the first target population to be encouraged to transfer? And then my third question is that when I looking at the continuing care for the CKD or ESRD patient in Taiwan, we have a very good program. This is the early CKD or pre-ESRD program. However, when I look at the registry, I saw that there are very few pediatric patients to be registered in this pay-for-performance program. Is it appropriate to encourage the care team to take more care about the pediatrician CKD patient? Then is is an easier way to transfer, or the transition will be more easier. What do you think? Thank you.
So thank you for Professor Xu, 3 questions. I think all 3 speakers wants to respond to Professor Xu first. How about Professor Herita? How about you? Maybe you respond to Professor Xu first, okay?
So the first question, the age of the formula?
Yeah, anyone.
Anyone? Okay.
Any question is okay.
Yeah, but as I said, we Japanese use original formula for Japanese pediatric patients to calculate EGFR, and this is utilized for 18 until 18 years old, and after that, the Japanese Nephrology Society formula for adult Japanese. So I think it depends on the nation or the body shape or something. So it is not globally determined. International determination cannot be settled, I think. Yeah, that's my answer to that.
Okay, I agree with Dr. Harita, because the body size is different, and maybe the equation should be different. As I know, in the Japanese Pediatric Nephrology Association, they have their own Schwartz formula modified in the Japan. It's quite different from the Schwartz formula. And I would like to answer the third question about the CKD program. Because we have a national insurance, so we have big data over there. And also the CKD program in Taiwan, we have initiated the CKD program very, very early. I think 2003 or 4, right? And for the CKD program in Taiwan, now we have early CKD and we have pre-ESRD program for the different stage of the CKD. But why the children has less registration for the CKD? I think that we can discuss about this, because as we know, in our CKD program, they majorly they just watch for one is for the hyperlipidemia, and we say 3 high hyperlipidemia, and about the high glucose and hypertension, and the including criteria we need to know to check the lipid profile, and also we need to check the proteinuria in our CKD program, and in the literature or in my report, you may notice that in the children, the etiology of the CKD in the children, more than 50% is Kakut. And the Kakut group, they don't have proteinuria, maybe they don't have hematuria. And also in the children, we don't have hyperlipidemia so high, and we don't have the high glucose. So if under the criteria now for CKD program in Taiwan, our Kakut patient is not fulfill the criteria. So that's why Professor Xu asked the question. That's why in our registration, the pediatric group CKD not included in there. And that is what we want to do in the future. And maybe in the future, our government can modify the criteria for the CKD for the children, and not the same with the adults. So that maybe we'll show the real instance and the prevalence of the CKD in children, and other than the adults. So that's my question for the third one. Yeah. So you have any comment?
How about question 2? I'm very interested about question 2. Question 2 is about what's the urgent disease need to be transferred. I think that's a very important. That's all. Do you want to say something? Okay.
I'm a doctor, a nephrologist, so I have a little experience about this discussion. But I think this patient have multiple complex of CKD, so we need to consider very widely for the timing of the transfer. Yeah, so my question, my answer, yes.
Yeah. So how about Dr. Harita in condition in Japan? So do you recommend what disease or what stage for the pediatric nephrology patient should be needed too early to transfer to the adult group?
Yeah, it depends on cases, and especially the extrarenal problems, such as neurological or psychological problems. For example, that MCNS, minimal change nephrotic syndrome, or IgA nephropathy, or lupus nephritis are easy to transfer to adult nephrologists because they see those similar diseases. So, but CACUT, especially with various extrarenal complications, it's very hard to transfer to one nephrologist because the patients need several related specialists. So we feel very hard to difficulties in transfer of those patients, and but generally that our health system is defined 14 years old as an pediatric in the pediatric department. So it is about 15 years to 18 years old, as Dr. Chun-Lin Cho mentioned, that it's the period for preparation for general Japanese kidney disease patients for transition. Yeah, regarding the topic, I have a question, and because it is very important for manage as an academic society rather than one pediatrician or one adult nephrologist. So we are making those guidelines for adults nephrologists and by those two societies for adult nephrologists and pediatric nephrologists. So do you have those collaboration of academic societies to achieve those transitions in Taiwan or other countries?
Okay, I answer first, and then the Dr. Chen, yeah. Because I'm the pediatric nephrologist, and he's a adult nephrologist. Yeah. So this is a very good question, especially for Taiwan, and this is our initiation of this topic because after we discussion we thought this transition I think is very important in Taiwan right now, and it's also we don't have a very we don't have a good program for the transition by now in Taiwan. So the two society always cooperation for many years. But I think in the future, this topic may be the major one we can discuss in the future. So, what is the character of the pediatric nephrologist, and then how to transit or how to transfer to the adult nephrologist. So we hope after this meeting, maybe we have new consensus about the transition. Yeah. So next, Dr. Chen.
That's a good question. As you know, we both service in Kaohsiung Veterinary General Hospital. Hospital. Okay, and Dr. Chiu is current Secretary General of Taiwan Society of Pediatric Nephrology. I'm a former Taiwan Society Nephrology Secretary General. So we both have the same idea.
Yes.
So we initiate the program. So I think that's a beginning time for Taiwan. So maybe in the future, we will some question for you. I think maybe we have a cooperation with Japan. We will ask you some experience. Maybe you can help us to establish, this kind of very successful transition program in Taiwan. So in the future, I think I will contact with you by email or by anything. Okay.
Me too. Okay.
I think I want to respond to Dr. Xu about your question too. What's urgent, but I think urgent group need to transfer to transfer and the transition. That's a difference. I like to say transition because transfer only pass to another doctor, but the transition we need to have a document. And that's a detailed document. That's a transition. That's my idea. I think a transition depends on different country or different society, different insurance system, and the patient, him or herself, and the doctors depends on that. But according to a publication, early transition. I remember early transition is focused on glomerular disease, and the later transfer is Kaku disease. But these two kinds of disease is the most causes of CKD in pediatric. So that's a real, I think, a real world. So the GN case, that's a urgent group to transfer because of because it's like a immunosuppression treatment or like steroid or cyclosporin, maybe adult, I would say adult nephrology, maybe the better experience. Yeah, I would say that. Because of most of the GN case in adult nephrologist, I would say that. But in Kaku, most of adult nephrologists, we don't know that disease. Yeah, that's my comment. Okay. Any question?
Hi, I'm Lin Yuyang from Taipei Veteran General Hospital, and I will ask about a difficult case. Actually, the young man is my patient since he was an infant. His problem is quite simple. It's mild to moderate hydronephrosis of left side. And when he grew up, he became a soldier, and he entered the school, military school. And then when at the third year, and his school asked him to have an examination to make sure the renal function of him is normal. So the estimate GFR is normal, but the school asked he should receive the GFR examination by nuclear medicine examination, and both of the kidneys should be more than 50 milliliter per square meter per 1.73 square meter and per minutes, and then they can be accept, or the student will be dropped out from the military academy. So unfortunately, the examination is not so good one of them is more than 50, but the other one is only between 40 to 50. So I have discussed with the doctor of nuclear medicine, and they told us they have no normal range for the adolescent. So my question is, do we have any reference for the nuclear medicine, for the GFR, for the adolescent or adult? And that's my question.
Okay, there's a question for the Dr. Harita and Dr. Zhou. Do you have any answer?
Yeah, I don't think we have a specific formula for addressing patient to measure EGFR by centigram or something. So the answer is we know is in Japan, I think. How about in Thailand?
Dr. Zhou? Do you have experience about this?
I think this case is very complicated case. So we need to know the patient's condition and care about their feeling and something wrong. Yeah. So many challenging cases. Yeah. So I have no comment about it. Yeah. Okay.
So in my opinion, this is really a problem about this. So this is maybe due to the examination. The method of examination is different, so we'll show the different result about this. So the Dr. Yang's question that raise a problem about now for the children, especially in the young adult, around the young adult to the adulthood. The examination is not enough for the real world. So I think this in the future we have more things to do when the normal population and the different method to estimate the GFR. What is the better one? I think now we don't have the real answer for it right now. So is that for the Dr. Yang? Okay.
He has visited 3 hospitals, and all of them are not so adequate for the military school. So the child come and cry every time because after 3 years, he have study over there and he will be dropped out. So I think maybe we can give some suggestion to the military school. Maybe they should have the announcement at the beginning of the entrance and then not at the end of the high school, and they tell him, I'm sorry, you have to be dropped out from the military academy. Thank you.
Okay, thank you. Thank you for Dr. Yang's question. So do you have any question from our online or our audience right now? Okay, I think the time is almost there. So I think today I'm very thanks for the Dr. Harita and also Dr. Zhou and also every audience online and physically here. Now we have a very good lecture and a good discussion. So thank you everyone. So hope to see you future really in Taiwan.
Yeah.
Thank you. Thank you.
Thank you very much.
Thank you. Thank you. 拜拜。拜拜。拜拜。
拜
拜。好，谢谢大家。那可以去吃饭了。那下午就1点开始下午的 section。好，结束了嘛哈？没有。然后这个问题很重要，其实应该要改的是国防部，不要用那个标准。我刚没有讲，他们应该要随时代进步，用不同的1.8。就是不一样啊，就是。
那是好久不见了。所以你现在都到金国里去了嘛？所以你就没有这样的。 ever conducted in North America. Now, in his 18th year, she has a lot of
dialysis.
And they transfer care from the pediatric center to the adult center. And our pediatric
support the transition and to the implementation of the transition. The patient, after
our chats we have seen so far,
I don't think
it's about
nephritis.
and this one
the GN case
different.
I think
and this one
To the on the other nephritis, CKD should be managed in our challenges with you. First of all, I'd like to review the current state of itis. So aren't there in care
will show 不要那个标准。
对对对，自费一盒要2万钱，一盒就可能可以吃1个月到3个月。哦，那应该每天要吃，至少一定要得吃，至少一天至少要1颗吧。对，它理论上是2颗。所以这大吃药很贵啊，贵，乌龙还是比乌龙还是贵，对不对？我还以为不会太贵。那时候买原料药，我觉得还好，比较起其他的东西。用到人身上就贵了。
应该是已经开了。Good afternoon. I'm Yuan Yo Cho. It's my great honor to welcome everybody to here enjoy afternoon meeting. The first speaker is me, so introduce were by Dr. Huang. Okay.
Thank you, everyone, and welcome to the 2021 ACPN meeting. And it's my honor to introduce Professor Chiu. And Professor Chiu is graduated from Kaohsiung Medical University for his MD, and he got his PhD degree from National Cheng Kung University. And he is currently the professor and the director of pediatric nephrology in the National Cheng Kung University. And today's talk is focused, Dr. Chiu's talk is the role of microRNA in autosomal dominant polycystic kidney disease. And let's welcome Dr. Chiu's talk.
Thank you. Thanks for Chairman's introduction. And thank you for symposium to invite me to share my result of role of microRNA in autosomal dominant polycystic kidney disease. Yeah, as we know, autosomal dominant polycystic kidney disease is the most common genetic cause of chronic kidney disease, especially in adults. In general, the mutation, the major part is due to PKD1 gene. The minor is PKD2. But very minor is due to unknown, no significant mutation site. It's near around 9%. However, there are 1 to 2% of ADPKD patients will present an early manifestation clinical cause. We show here several renal echo images, but they not cohort study from the same patient, from different patients. But we can understand it from here. There are from 2 months old till 74 years old. We can find the renal echo showed in younger age, there are only little or minor cystic formation, but when during growing age, we can find the cystic formation will gradually enlarge, even destruct their normal architecture of the renal structure, okay? In this slide, we can find total kidney volume were inversely correlated with eGFR. Okay, so this means if total, in here we can look the higher the total kidney volume, the lower the eGFR. So this means there are some acquired factor that exacerbate the renal function. Then, according to this, so it may indicate that growing cyst will promote massive enlargement of the kidney. So how to initiate the process? Here show a simple schematic diagram. In A, we can understand that germinal mutation in PKD1 or PKD2 do not directly cause tuberous cell to hyperproliferation, but proliferation and the cyst formation might require their germinal mutation with concomitantly with other somatic mutation or chemical injury. This means second hit or even third hit. And this would not necessarily affect the polycystin on the normal allele and could instead disrupt other related genes. This means dosage threshold for polycystin might determine the timing and the extent of cyst formation. Okay. If proliferation of tuberous cell in response to growth factor results in expansion of tuberous cell, tubular wall, which start to bulging into interstitium. A point is reached at which the nascent cyst breaks free of the parent tubule, becoming an autonomous cyst. The separation of the cyst from the tubule might occur as a result of tubular apoptosis, but which occur via an unknown mechanism. The cyst expands and fills with fluid that is secreted into it by a mechanism involving cyclic AMP-mediated chloride influx and arginine vasopressin driving fluid. We have PKD animal model like kindly provided by Professor Zhang that utilize an inverted MC1 neomycin resistant gene flanked by two LOXP sites was inserted into intron 34. And this animal model, it can induce cyst formation depending parallel to the edge. And compare with previous PKD animal model, previous animal model always lethal, perinatal lethal. So we cannot utilize previous animal model to observe their chronic effect. But in our animal model, we can look in after birth, they even can grow into 4 months old age, and we can cross monitor their cyst formation and growing. Okay. Besides, we think microRNA is endogenous. He can regulate mRNA expression in post-transcriptional level, either via translation, repression, or mRNA degradation. So we think if we consider a quite factor that mRNAs maybe have his role in the PKD progression. About the nephron with relevant change with the relationship between nephron and the microRNAs. There are several papers has reported that in here, okay, numerical number in bracket indicate total number of microRNAs that have been predicted from database, okay? So we can find that there are many mRNAs could be affect each nephron segment. Besides, in the same paper has showed that some microRNA has been studied in particular some diseases. For example, in fibrosis, renal fibrosis, in renal cancer, even PKD2 disease, or hypertension-related kidney disease, even diabetic disease. So there are many microRNA has been studied in different renal disease. Okay, we think Kito has provided his study paper in heat map on venous expression in red tissue. We can, according to heat map in here, members of mere microRNA 200 family highly expressed in exocrine gland and the epithelium. Furthermore, the level of microRNA family were higher in the proximal tubule than in the glomerulus. Okay, so in here we can provide, before provide a brief summary, we can further, other published data tell us microRNA can upregulate ECAD heparin through ZEP1 transcription factor, and that could influence AKT expression. Besides, chromosome expression was inversely correlated with oxidative stress and microRNA 200C in human renal disease, such as oxidative stress. It will induce microRNA 200C bind to the chromosome mRNA 3' UTR, and then resulting in reduced chromosome expression. In our animal model, PKD1 animal model, and when compared with B6 mouse, we also perform microRNA array, and we can find microRNA 200C can express higher level than control mice. So we think, what's the relationship between them and the PKD formation? Okay, so at first, we show the evidence that microRNA-C could express in PKD mice, in PKD epithelial cell, in human or in mice, rather than control human or control mice. So we utilize in situ hybridization to detect the microRNA probe, and fluorescence indicate microRNA 200C evidence. So we can see between normal and the PKD patient, the renal epithelial cell, the luciferase is very high expression than normal renal tissue. And in mouse model also have the same result, okay? So we can provide evidence that microRNA-C expression is significant. For this reason, we provide some renal in vitro cell line culture system. Based on N1 cell, we create N1 over microRNA 200C overexpression cell line, and the anti-mRNA 200C overexpression cell line, and the co-transfection mRNA 200C and the anti-mRNA 200C co-transfection cell line. In this data, we can find that in overexpression, polycystin mRNA level would be decreased, but in anti-mRNA 200C, it will reverse its level even more PC1 protein level. But when co-transfection, it will equal to control. So we understanding 200C may affect polycystin 1 protein level. Further study, we should provide evidence that 200C can target to PKD1 messenger RNA 3' UTR, because we understanding that microRNA always binding in 3' UTR, and in PKD1 3' UTR sequence, there are 3 binding sites that can be bound by microRNA 200C. And the first 2 binding sites is completely complementary to PKD1 3' PKD sequence. But the third sequence is relatively similar. So there are 3 binding sites that could be bound by microRNA 200C. In this, we utilize Lucifer's reporter assay. If they can bind by microRNA 200C, the Lucifer assay will be decreased. So we can find in 3'UTR2 binding site or wild-type binding site, the Luciferase always be down regulation. But if we create a mutated that disrupt their binding, their Lucifer's the assay, the Lucifer expression will be reversed. That indicates microRNA can direct bind PKD1 mRNA 3'UTR. So it can direct affect their expression pattern. Okay. So we can provide a brief summary. That is, polycystin 1 level is inversely correlated with MER200C overexpression in ADPKD. The second, microRNA 200C can target the PKD1 3'UTR and suppress PC1 expression. Then we want to study their physiological, biological function, and we can find in microRNA 200C overexpression cell line, not only in human or in mouse, they can induce cell proliferation significantly. Another we can find, we utilize 3D gel system culture, and we can find in overexpression cell, both in human and mouse, overexpression 200C expression cell, they can promote cyst formation and the cyst number. Yeah, you can see the microscope picture. Okay. For this reason, the evidence is they can provide the proliferation and cyst formation. So we want to study the mitogenic signal pathway may be affected by their subsequent effect. So what's the mechanism that could induce the suppression of PC1? So we want to further study, and we utilized RT-qPCR for mitogenic signal pathway array, and we can find when compared to microRNA 200C overexpression and N1 cell, we can find IGF-1 and insulin-like growth factor 1, insulin 2, they all have significant folding change than normal than N1 cell. Otherwise, PI3K always and AMKG3, PKC, RISC3, regardless, always have the same pattern. Yeah, it means IGF-1 signal pathway may be enrolled in their biological function. So we, according Western, to study their signal pathway, and we can find MER200C overexpression and compare with anti-MER 200C overexpression or in the co-transfection. And we can find, we can look, their expression is quite different. In overexpression, we can find phospho IGF-1 receptor is very significant high level, and they may be inhibited or lessened by anti-MER 200C or co-transfection. Not only phosphoinsulin growth factor, but also PI3K, phospho-AKT, phospho-ERK, and phospho-P38 all have the same pattern. Yeah, okay. If we add BMS 536924 image IGF-1R receptor kinase inhibitor, yeah, we can find if we add in the inhibitor, it will decrease their downstream signal pathway. in vitro cell culture show this result, and so we were validated in tissue specimen. In this slide, we can find in ADPKD patient, let's control. Upper panel is control tissue, and the lower panel is ADPKD patient. We can find phosphate IGF-1 receptor, PI3K, phosphate AKT, phosphor ERK, and phosphor P38. They show relative high impression antibody protein expression that is brown color. Sorry. Not only human, but in PKD1 mouse, they have the same expression. So we can find the significant brown color in our even cyst epithelium cell or small cyst epithelium cell. They show relative variable different changing. Then we want to know if we block the downstream signal, that maybe reverse their presentation. So we provide the IGF-1 promote cell proliferation and their downstream inhibitor. In left panel, we can find that if we add the IGF-1 into supernatant or culture medium, we can find their proliferation even higher than control group. But if we add the IGF-1 kinase inhibitor, they will inhibit their growth factor. Besides, if we add a downstream inhibitor, they also reverse their proliferation. Even another provided IGF into IGF growth factor 2 supernatant, they also be inhibited by their downstream. They showed in microRNA 200 cell experience cell line. Yeah. Not only in proliferation, but also in cyst formation. So we can calculation and we can find the cyst will be near 0, okay? Yeah. We know PKD and the control, they are showed with significant microRNA expression level change. But we want to know this expression change, how about to the edge? So we study from different edge of kidney tissue, and we can find microRNA expression in different edge is gradually elevated its expression. So something like may affect mere 200C, and the expression will gradually increase its expression, and it may related to cyst formation and the cyst growing. So another brief summary is microRNA 200C in PKD, it can activate IGF-1 with its downstream signal pathway. And then when IGF-1 signal pathway it be activation, it will promote the cell proliferation and the cyst formation. And we can, from animal study, we can note microRNA 200C parallel to IGF-1 receptor, INSR receptor with time sequence in PKD1 mice. So we can provide a simple schematic paragraph that induced in here is microRNA will inhibit the polycystin 1 and then decrease its expression, and then it may induce IGF-1 receptor, and then downstream PI3K, AKT, P38, and ERK1 and 2. But this downstream pathway can be blocked by different inhibitor, and then they may affect the cell proliferation and the cyst formation. So till now, we want to, we think further, that is, if microRNA 200C, it may affect cell proliferation and cyst formation. Now, how can we utilize it into therapeutic possibility? Okay. So, as we know, we understand the microRNA it can secreted to body fluid such as blood, but it may be degraded by RNase. So we try to prevent this degraded process. We utilize nanoparticle to encapsulate with microRNA 200C. That is our schematic synthesis diagram. We use novel amine magnetic iron oxide nanoparticle, and this nanoparticle will ligated with arginate, and then it can encapsulate with in our hypothesis that we utilize anti-mer 200C plasmid. It can be inserted in arginate, and then calcium ion role as stopper. Okay, so it can encapsulated as encapsulated core-like structure. Besides, we can in this outlier we can ligate it with tissue-specific protein. This is specific for binding specificity and efficiency. So for target organ is kidney. So we provide anti-kidney specific protein. This is the cadherin 16. Because cadherin 16 is highly expressed in basal renal epithelial cell, especially in basal erythrocyte. So it can increase her adhesion and then be up intake to cellular. Yeah. The real size of our nanoparticle is real size around below 10 nanometer, but in fluid they create a hydrodynamic diameter. So we can find the hydrodynamic is around 100 to 200 nanometer. So can they penetrate to glomerulus? In general, in glomerulus capillary, the fenestrator is the diameter around 100 nanometer. So they may be partially penetrated to capillary. Glomerulus capillary, the fenestration size. But if we pass through glomerular base membrane, the size has better lesser than 6 nanometer. So major of our nanoparticle, is not really penetrated through glomerular filtration, but it just through vascular supply to basal erythrocyte. Okay. So according to our design, we can find in vitro cellular to test their uptake efficiency. We can find if we did not add ligated with AKSP protein for tissue specific binding, we can find the cellular uptake will have difference. Rhodomin 6G is red color, so we can find if they can uptake into cell, they are presented with red color. Okay, so in AKSP target nanoparticle, we can find that the relative fluorescence intensity was very higher than non-AKSP binding nanoparticle. So it means AKSP binding to nanoparticle in vitro cellular culture system, it can enhance cellular uptake. Besides, we can find in primary microRNA 200C transfect cell, it will have proliferation. But if we add where nanoparticle in culture system only, we can find they will reverse their proliferation. And the efficiency can prolong more 4 hour, 8 hour, even 24 hour. They have the same pattern. We validated with PKD1 primary cell culture, and their results have the same pattern. So we understanding in vitro culture system, we understand where nanoparticle is work. And besides proliferation, we can find is functional cyst formation, and we also can find with AKSP nanoparticle compared to without AKSP target, we can find the cyst size is quite different. Okay, in N1 cell, they just tubular-like structure, so we can understand in the cyst size they're quite different. Okay. Yeah. Previous study is in vitro culture system, so we validated this data in vivo study system. So at first we injected a nanoparticle through mouse tail vein, and we can notify this nanoparticle biodistribution. And we use in vivo imaging system imaging. We can find the nanoparticle accumulated in renal, okay? But when we extract the organ through ex vivo, we can find not only kidney but also liver. There also has a high expression of R6G immunofluorescence pattern, okay? So this is IHC for KSP in the kidney distribution, okay? So we can confirm not only AKSP nanoparticle or only nanoparticle, they all can be accumulated in liver and the kidney. So this slide cannot convince for us to emphasize the tissue-specific binding, the importance of tissue-specific binding, such as AKSP, the necessary for AKSP, the ligation to nanoparticle, because with AKSP or without AKSP, they all show relatively high intensity expression. So, but we use inductively coupled plasma method, okay, which extract the tissue and which calculate their ion content. That we can find without the AKSP tissue specific to nanoparticle, and with AKSP specific target nanoparticle, we can find as IVS data, liver and the kidney also has high level. But if we add the AKSP special target binding protein to nanoparticle, it can enhance their intensity in specific tissue. Okay, after 1 day, 24 hours, we can find liver accumulated in liver still can be found, but the intensity or the amount is decreased than 2.5 hours. And in kidney also have the same picture. But we can find the most abundant ion can be secreted from urine, okay? Not only AKSP or without AKSP, but AKSP will have more concentration level than non-AKSP group. So this indicates we use this nanoparticle, it will not induce ion accumulation in body. So later, finally, we must try their effect in in vivo the animal study, and we can find we do 2 animal studies. The first we just do we certify in day of 21 because what type of PKD1 mouse, most of them will die in day of 21. And we just provided 3 dosage. And we can find in 21-day monitor, in pathology finding, we can note that the sister number is quite severely less, smaller than wild type. Okay, that's without AKSP. But in biochemistry data, we can find without the treatment, the BUN is high level, but after received the AKSP nanoparticle, the BUN level will decrease, will not elevated so high. Again, sister size is okay, they have significant different, but sin number is near no significant different. So this is sacrificed in 21 days. Another study, we cross observation their survival possibility. We can find in the same study protocol, we can find in mice without any treatment, they nearly total mortality in 32 to 33 days. But if PKD mice receive the treatment, they even 60% they can survive till 3 months. Okay, in histology we can find that they also still have sister formation, but relative in 36 days, the sister is different. It's smaller than without the treatment. But in 88 days of 80 days mice, the sister still near the same as 36. But if we observe the biochemical data, we can find that the creatinine in 36 days is near the same as control, but in 88 days, the creatinine is still higher, near around without the treatment group. So it means receive nanoparticle treatment, they can inhibit the sister progression, but it may only lessen or decrease their progression and prolong their life. Okay. So another brief summary. Antimer 200C encapsulated nanoparticle can inhibit cell proliferation and the sister formation in PKD serial model. Okay. If we combine antimer plasmid and the nanoparticle, has potential clinical implication to lessen the progression of PKD disease. Okay. In our conclusion, MER200C have emerged as new regulator of ADPKD pathogenesis. Anti-MER200C may present a feasible and an entirely new class of drug for ADPKD. Okay. Yeah. I should acknowledge Amanda as our collaborator to show in this slide. And finally, thank you for your attention for our audience. Thanks.
Thank you, Dr. Chou's talk. And we will keep all the questions and in the end of every speakers. So next, I will invite Dr. Chou to introduce our next speaker.
Oh, okay. Yeah. It's my honor to introduce Professor Zhang. Professor Zhang is a senior researcher in National Laboratory Animal Center. He is a PhD graduated from the Institute of Basic Medical Science at Cheng University. Okay. And his research interest is in functional genomic, translational medicine, and nephrology and disease animal model to more developmental and application. He has assisted in many research on genetic knockout or transgenic mice in Taiwan and contributed a lot. Also assisted in publishing many important articles. So let's welcome Dr. John to present here. Thank you.
And thank you for the introduction of Dr. Cho. And good afternoon, everyone. And the title of my speech is Mouse Model for Polycystic Kidney Disease. In my speech, I will talk about 4 animal models, major mouse model for the polycystic kidney disease. All the 4 types of animal model was genetic modification animal model. 3 of them was targeting up on the major defect gene in autosomal dominant polycystic kidney disease, PKD1. The final one was targeted on the other gene we named WDR19, also called IFT144. It's a major component for intraflagellar transportation in the major defect organelle in polycystic kidney disease named primary cilium. So a lot of gene defect in the primary cilium will cause the polycystic kidney disease. So we also call another special name ciliopathy. So the final one is focused on the ciliopathy. This is the common introduction of polycystic kidney disease, and all the introduction I think Dr. Cho have introduced so pass away. So the major defect gene in the autosomal dominant polycystic kidney disease is a PKD1. Okay. However, it's autosomal dominant. That means only one gene defect in PKD1 that will cause the disease in human being. So the defect gene, the mutation site in the defect gene, we analyze the point mutation, major point mutation. Okay. After analysis, we find all the mutation will cause the out of function of the PKD1 gene, not the gain of function. So from this study, we know all the defect was caused the loss of function of the major defect gene PKD1. In attempt to rewrite the function of the defect gene, in attempt to realize the major function of the PKD1, so a lot of scientists to figure out the localization of the PKD1, and they find the PKD1 is a transmembrane protein, major locate in the spatial organelle we call primary cilium. Each cell have only one primary cilium. The function of the primary cilium is antenna, just sense the outer environmental clue, including chemical include, or the mechanical include. And in attempt to generate a model for PKD1, I think we will focus on the defect gene. So in the 1997, the first one PKD1 knockout mouse was generated by Dr. Zhou Jin in Harvard University. He just knocked out the exon 35 of the PKD1 gene and got mice. And surprise, the mice, when she got the mice, the heterozygous mice, only one gene has defect. The other one is still normal. All the heterozygous are normal. Didn't develop any cyst in the kidney. Only the homozygote will develop polycystic kidney disease. But the disease progression is very, very dramatic, rapid. They cannot make the mouse live birth. All the mice was embryonic lethal. Okay. In addition to the kidney, they have the other defect, including in the pancreatic cyst, including the lung cancer, including the blood vessel defect in the lung and the other problem. So it's a multi-organ defect. So they cannot get the mice to live birth. So after that, a lot of scientists generate a lot of different kind PKD1 knockout mice. All the mice are similar. Heterozygous, normal. Only the homozygote will develop very rapidly polycystic kidney disease or are embryonic lethal. So no any live birth animal can be used for the further study, either for some kind of drug treatment study, just like the Dr. Cho introduced in the previous talk. So no any live birth. So how to generate a live birth kidney model, animal model for PKD? So in my idea, it's a multi-organ defect disease. So I will focus on the kidney. So we try to generate a PKD1 conditional knockout mouse, just disrupt the PKD1 only in the kidney, not the other organ. By this way, maybe we can get a live birth animal model for polycystic kidney disease. In this strategy, we must generate two kinds of animal. The first one is PKD1 flox mice. We should insert 2 log species in the intron of the PKD1 gene. The other one, we want to generate a kidney-specific recombinant expression mouse. It's a change mouse model. So we use the kidney-specific promoter, KSP, also known cadherin-16. Cadherin-16. We use the cadherin-16 promoter to drive the Cre recombinants. Also, and then we got the 2 mice. Intercross them to generate a double change mice. In the kidney, only in the kidney, they will express the Cre. So only in the kidney, the PKD1 will be knocked out. All the other organ, the PKD1 is still intact. By this way, we can generate a real conditional knock-out mice. We hope the mouse can live birth and then use the model for other study, for the drug treatment study or some other mechanical research study. This is our design of the PKD1 conditional knock-out mouse. This is the flox mice. At that time, we just insert neo-cassave. They have 2 log speed flank the neo into the intron 34. The third log speed insert to the intron 30. Flux to the exon 31 to 34. This is our design. At that time, we use the embryonic stem cell. So the neo should be inserted into this side. So we got the mouse and began to breed. And we found when we breed the mouse into the homozygote, at first time, we didn't delete the neo. The neo is still in here. For the further study, if you really want to get a conditional knock-out mice, we should delete the neo. But now we didn't delete the neo. We just breed the mouse and see what happened. We found the mouse after intercross generate the homozygote. We know we named that L3, L3. L3 named 3 log speed size, so we call the mouse L3, L3 homozygote. We got the mice, and the mice was live birth. They didn't dead. They didn't cause any embryonic lethal. So we got the mouse and extract the RNA and the protein from the kidney to determine the PC1. That means the protein product of the PKD1 gene. To determine the PKD1 expression and either in RNA and the protein level. And we found the RNA level and the protein level was dramatically lower than the normal mouse. The experiment level is only about 10% as compared with wild type mouse. And these mice are live births. And what happened? They really caused them polycystic kidney disease. This slide was shown in Dr. Cho's slide in the previous talk. You see the disease progression is very rapidly. But however, you can see the coat color is dramatically different. This is the brown, this is the just like golden, even have some black. Because at that time, we use the embryonic stem cell to generate the knock-out mouse. The embryonic stem cell is derived from the 129 SVJ mice, not from the B6 background. But we breed them with B6. So the mouse in here are mixed background. They are mixed background contain the 129 SVJ and the B6. So the individual variation is very huge. So they are not very easy. It's a boundary for the further usage of this model. So in this mouse model, more than 17% mouse was dead before 1 month old. Only 30% can live longer. But when we backcross 10 generations to the B6 background, all the mouse was dead before 1 month after birth. No other exception. So we got the mice and began to other usage to, like the Dr. Cho, take the mouse to treat some kind of drug. So however, from this study we find haploinsufficiency. Haploinsufficiency could be an alternative mechanism to induce the PKD, not only the 2-hint or 3-hint model. I think haploinsufficiency may be the major model system to induce the disease. Okay, but however, we still go ahead for our primary goal to generate a conditional knock-out mouse. So we remove the neo after backcross 10 generation and remove the neo and close the mouse with the Cre mice and got what we done. This is our conditional knock-out mouse. All the mice was dead before 2 weeks old. They also develop a very severely polycystic kidney disease. You can see the kidney is very huge as compared with wild-type mouse. So now we got 2 types of PKD model. The first one we call hypomorph. They just have a neocassette insert in intron 34 of PKD1 gene. They cause the PKD1 gene expression lower than wild type. They didn't know about PKD1. They still have only about 10% PKD1 expression. So it's a low expression, right? But here is real newer of PKD1 in kidney. They still have more severely PKD1 model than the hypomorph, than the previously not like something like the knockdown mouse model. Okay, so we got the second model is more severely than the previous one, hypomorph model. However, when I talk about the haploinsufficiency model system, that means only one allele wild-type PKD, they cannot express enough PKD1 to support the kidney development and induce the PKD1 disease. In an attempt to support this hypothesis, we must generate a PKD1 real knockdown mouse. The PKD1 expression may be lower than wild type, okay, to support my idea. So we generate a real knockdown mouse by microRNA. But here, this microRNA is not the natural microRNA like the MIR200C by the Dr. Cho introduced in previous section. It's an artificial microRNA. I use cell culture system to prove the microRNA function in the PKD1. It's real artificial microRNA. Okay, this microRNA was designed by a website in the In Vitro Gene. It's a commercial company. They have set up a lot of artificial microRNA library. So we pick up two of them and test up on the cell culture system. Prove that are function well to inhibit the microRNA, to inhibit the PKD1 expression. And then put these 2 microRNA downstream a GFP reporter. All this knockdown cassette was downstream a ubiquitous promoter. This design was a conditional knockdown. In the first design, we use a ubiquitin promoter. It's a ubiquitin promoter drive a death ray. There are 2 log speed flanking the death ray. After remove this death ray, they will change from red to green color. And the microRNA was inserted after the GLP. So when we see the GLP expression, that means the microRNA was also be expressed. They have a real function to knock down the PKD1. So this is our data. The first style out here, you can see some mice are red color. So we got the mice break up and close the mice with the Cree recombinant mice to get the pop-out model, so we can see the green color. We got a green model. We got a green color mouse to grow up and find what happened in this mouse. Whether the mouse really have expression the microRNA to knock down the PKD1. We got a 3 line of changing mouse. The TG2 and the TG3 line, they can expression higher EGLP and the higher microRNA against PKD1. So the PKD1 protein expression was really lower in these 2 lines. So we take these 2 lines as our main model for the PKD1 knockdown mouse. The expression level in these 2 mouse is about 30 to 40% of the wild type mouse. They are higher than the hypomorph model. They are really a knockdown mouse model. And finally, we want to know, when we knock down the PKD1 expression level from the 100% to about 30%, what's happening in the mouse? Once again, they can induce polycystic kidney disease, but the disease progression is more milder than the hypomorph or the conditional out. Okay, this is the third type of animal model we can generate. So using this model, they can still alive for 1 year old is okay. So some doctor in Taiwan, they want to try some Chinese medicine to use them for the PKD. So they asked me to share this mouse model for them. They can treat the Chinese medicine. Everybody know the Chinese medicine is to take the medicine for a long, long time. Right? maybe you can see some effect on the mouse model. So we got the mouse model to share them for the further analysis. And the section shown here, you can see the cyst number and the cyst size is gradually increased depending on the age of the mouse. Okay, the final one is focus on the primary cilium. Okay, the primary cilium is a special organelle. Okay, in the kidney epithelium also have a primary cilium. The major defect in PKD1 connecting this idea to the primary cilium was induced by Dr. Zhou Jin. They found the PKD1 was located in the primary cilium, and they can push the primary cilium by mechanical stress, shake the primary cilium. They will cause the calcium influx. See the calcium signal. So everybody know, oh, it's a major defect in this special organelle. Okay, so the PKD1 gene located in the primary cilium, but what the real function? I think we just know maybe involved in the calcium, but they still have some other hypothesis talking about maybe involved in the other signal transpaction way. But right now, it's still a lot of hypotheses there. So right here, we want to introduce the function of the primary cilium in the PKD1 disease. So we focusing on one of the major component in the intraflagella transmutation we call IFT144, also named WDR19. They are involved in the retrograde transportation. That means they can be responsible for the transportation protein from the tip to the basal. This is the antegrade, this is the retrograde. The IFT144 is responsible for the retrograde transportation. So we generate, once again, a conditional mice. We first generate a WDR19 flox mice and made them with the Cree was expression specific in the kidney, the Caterin 16 Cree mice. So he briefly then got a double change in mice and see what happened. Yes, he really also got a polycystic kidney disease. You can see when the aging up, all the mice was developed polycystic kidney disease. Okay, but interesting, when we compare these mice with previously PKD1 condition mouse model, is a very interesting data show here. On the upper panel, you can see this line is WDR19 conditional mice. This is about day 10 after birth. The upper one is PKD1 conditional mice, also at about 10 days. You can see the disease progression in PKD1 conditional is dramatically severe than the WDR19 conditional. Okay, all the PKD1 conditional mice was dead before 2 weeks old. But WDR19, they can survive to about 3 weeks to 4 weeks. So the disease progression is slower in WDR19. Okay, why? This is the major topic in my laboratory. Now we are still going to figure out what's happening in that. I see this is the primary cilium structure in the electron microscope. This is a wild type. It's a long primary cilium in the renal tubule. This is a PKD1 conditional mouse renal tubule. They still have an intact primary cilium. Okay? So I think at this situation, all the cilium is normal, but they're just lacking the PKD1. So in my idea, in this structure, the structure is look normal, but the function is mal. So I think it's a malfunction of the primary cilium. But in WDR19, the primary cilium structure is severely defect. So in this structure, I think no any signal can be transduced from the primary cilium. No any clue can be sensed from the primary cilium. So it's a complete loss of function of the primary cilium. But what was the outcome? In our previous section, previous slide, you can see. This one is just malfunction of primary cilium. The disease progression is very rapidly. But this one is out of function of primary cilium. The disease progression is more mildly. Why? Okay, I think we also try to analyze the molecular mechanism. We find in the WDR19 knockout mice, the cell proliferation is more slower than the PKD1 knockout mice. On the other way, the apoptosis index in the WDR19 is more dramatically higher than the PKD1 knockout mice. Okay, this is our primary data right now. For the further analysis, we are just going to investigation to realize what's the difference. But in my idea, I think all the PKD, the molecular mechanism should be happen in the developing stage. After they are developing, they are well-developed tubules. At that time, I think all things is fixed. You cannot repair anything. So all the thing was happened during the developing stage. They are going to the wrong way from the tubule to the cyst. When they are going to the wrong way to a developing cyst, I think is just there. You cannot rescue them, except you can, just like the IPS, to make them regenerate, to back to the embryonic stage. And then there may be some possible way to cure this disease. Okay, thanks for your attention. This is my speech right now. Thank you.
Thank you for Dr. Zhang. Very excellent and exciting research. And the third speaker is Dr. Huang. Okay. Dr. Huang is MD, PhD. He graduated. MD graduated from Kaohsiung Medical College, and his PhD degree just graduated from West Reservoir University in 2002. After graduated from his PhD program, he into our clinical nephrology training, and then in 2007, he just attending physician in Kaohsiung Medical University Hospital. And he also, in 2011 till 12, he just postdoctoral fellow in University of Michigan. And 2012 till 2014, postdoctoral fellow Boston Children's Hospital, Harvard Medical School. And however, in 2019 till now, he is an assistant investigator and attending physician in National Institute of Cancer Research, National Health Research Institute. His research interest, according to his lab description, he is interested in the genomic changes in human disease, including cancer and other hereditary disease. His lab applied high throughput genomic technologies to discover the disease-causing gene of human disease and drive genes of cancer. Translational researches in vitro and in vivo are used to validate their functional contributions to the disease development progression, along with the development of cancer treatment. Today, his topic is mutation landscape in Taiwan polycystic disease. Let's welcome Dr. Huang to present your study. Thanks.
Yeah, thank you for Dr. Chu's kindly introduction. And today my talk is our clinical work, and there is no functional study or basic cellular or mouse model study. And I'm very glad that Dr. Chu and Dr. Jiang already introduced this PKD disease very clearly. And my part will be only focused in the clinical part, especially the genetic mutations. So one of our goal in the lab is we want to know what's the PKD mutation landscape in Taiwan. So in the past 10 years, we work with more than 150 nephrologists all over Taiwan. That we have informal Taiwan AD-PKD consortium. And all these cases, they were collected from either medical centers, local hospitals, or outpatient clinics. And I believe those patients, they have the typical ADPKD cases, but also some cystic disease that the clinical doctor don't know what kind of disease they have, so they send these samples to our lab. And at the time, we are collecting all the patients' clinical data, and so that part we didn't finish. And today, we have more than 950 families. And first, in this part, we present our in-house panel, which contains at least 10 polycystic kidney disease-related genes. And these 4 genes, they are the PKD disease-causing genes. This GANAB and DNAGB11, they are the 2 new genes that found in the past 4 years. And we also examined the ARPKD genes and the ADPLD genes. And currently, we're also trying to do this Taiwan PKD registration for all the PKD communities. And currently, the following slide, I only showed the result about 750 families that we finished the analysis. So the method for this clinical study is we usually start with this long-range PCR because we know the PKD1 actually has 6 pseudogenes from exon 1 to exon 33. And next, it's just like all the next generation sequencing study, we have to use the Ambicom method to generate the library. And we use this Illumina platform followed by this CLC Bio genomic, sorry, it's a typo, genomic workbench. And we compare our data with the large Mayo Clinic PKD database. We also compare with our data with this ClinVar, and we use this ACMG criteria to classify our variant found. Follow our initial data, we have a specific group that we use this microsatellite analysis combined with genotyping and haplotype analysis to calculate specific mutations to understand the age of mutation that I will show you later. And following the currently work, we are continue our panel, in-house panel analysis, but we also are doing some whole exome sequencing and whole genome sequencing for the undiagnosed patients. We also perform this standard MLPA method for the large indel analysis. So the method, we also use this fluidine access array, which is a machine-assisted multiplex PCR that we can generate our library in less than 5 hours. And we use our in-house Illumina sequencing to do the sequence and followed by this CLC software or other software that we can use. And for this 750 families, so for this in-house panel, actually you can see we do have most of the patients that have this PKD1 mutation, followed by this PKD2 mutations. But if you look at the number, you can see our PKD2 mutation actually is much higher than the previous report in the literature. I believe this will be approaching like more than 30% in our cohort. And we also identified 6 families that contain that has mutation in this GNAB genes. We also found mutation in the ADPLD and this ARPKD genes. For the definite diagnosis, we state that we have five patients that has the 2 allele because this is a recessive mutation. And for other 30 families, we only found 1 allele mutated by our method. So the mutation profile, of Taiwan ADPKD, I also only listed these 4 genes here. So you can see most of them, they are this, sorry, it's here, should be here, it's the PKD1 followed by this PKD2. And this gene, the GNAB and the ALG8 mutation only compose of only 2% of our cohort. So it's true that most of the patients, they have this PKD1 mutations, but we have much higher PKD2 mutations in Taiwan population. So in terms of the mutation profile, most of the mutations in PKD1 or PKD2 we identified, they are pathogenic, most of them, and a certain degree, especially in the PKD1, and we identify like 20% of our mutation, they are missense mutation, and they are never reported in the literature before. And even we do the family segregation test, but since we didn't have this functional study for this PKD1 families, most of them classify them as variant of unknown significance. We do this in a more conservative ways to do our report. So in Taiwan, we have a unique phenomena because we found there are 127 families. They have exactly the same mutation in Taiwan, which is a PKD2 arginine AO3 stop codon mutations. So at the time, we want to know that what's the reason that we have so many exactly the same mutation in Taiwan? Because in the literature, if you're familiar with the PKD literature, that every literature says this PKD mutation, they are unique, they have private mutations. So in this project, we try to understand are those family, they are related, or this mutation have a hotspot mutation in the PKD2. So we do the haplotype and along with the microsatellite analysis around this PKD2 regions. So here we focus on this about 250 kb region to understand what happenings. In the next few slides, I just want to let you know that there are mutation in the database of these mutations. So in the TopMed or the genome AD, there are very few allele frequency, and you can see they found in the East Asian. So I believe these 4 family, actually, they are really PKD cases. And in the Mayo Clinical database, they only have 7 families recorded this one. So in a total of almost 50, or actually it's 49 mutation paper that contain this PKD2 mutations. You can see it's very rare. The first one is in 2001 from Cyprus, and there's 2 cases from France, and only 1 family from Canada. In this French study, they have 6 families, which is higher. And 1 from here, published in Korean 2 years ago, they have 4 families. So the percentage is relatively low, except this one, which is a smaller study that published 46 families from Taiwan. They found 3 families with this PKD2 arginine AO3 mutation, stop codon mutation. It's about 6.5%. So in our much bigger study, we found a much higher mutation rate. So for this analysis, we performed this Taiwan exome genome-wide array in the academic Sinica. And this array has more than 750 SNP probe that we use in 78 families, which contains 120 samples. And we found that in this specific region, which is about 250 kilobase range, we use this facing program to do the haplotype reconstruction to know their facing status. And we use this DMLE 2.3 software to calculate the age of mutations. So after we do the facing of this region, of this 250 kb region, we found that almost 80% of the family, they are exactly the same haplotype in this region, indicated that at least 80% of this 127 family, they are bloodly oriented. They are from the same ancestors. They are from the same origins in Taiwan. And in one of our families, you can see we have interesting features here is we found that the gene recombination actually happened in the families because, you know, the gene will recombine during the mitosis phase. So in this family, the two brothers, they have PKD2 mutations. But on your left-hand side, these two kids, they had this PKD2 mutations, but their haplotype, they are different on the outside region, except this in the center region, they are exactly the same, but in the outside region, upstream and downstream, they are different. So the most likely cause of this is recombination happened in the father in this generation, that actually the facing will be run out in the outer region, but they keep the PKD2 803 region exactly the same. So this indicates that even we only found 80% of this family, they are from the same origin, but if the gene recombination occur in the family, actually the frequency should be higher in the population. So another question is, people will ask, where do you collect those samples? Are they all from the same city? So it's not surprising if all these patients, they are relatives. But actually we collect patients from all over Taiwan, from the north part to the south part. And there's one family in Penghu area, which is a small island outside Taiwan. They all have similar percentage. We have more patients from the southern part of Taiwan, and we have few patients from the east side of Taiwan where there's less population. And there are in 3 counties we haven't have any patient. So in general, this mutation was distributed relative evenly in all over Taiwan. So I believe this will be another question, is that this fungal mutation should happen very early in the history if it's migrated from some place to Taiwan. So, okay. So if we use the analysis to do the calculation, we estimate if one generation is 25 years, so this mutation supposedly happened about 30 generations ago. So it would be 300 years ago. That's the first people, the first founder that arrived Taiwan from the statistics point of view. So in Taiwan, we have a large family population with this PKD2 arginine AO3 stop codon mutation. It's about at least 80% of this family, they have a common haplotype. So I believe they are from the same ancestor. And this founder was estimated to be de novo in Taiwan, or it arrived in Taiwan about 300 years ago. So what happened 300 years ago in Taiwan? So it should be the time, is the end of the Ming Dynasty, which is 1683, and the early Qing Dynasty, that's the Qing dynasty allowed people from China and migrate to Taiwan after 1724 in the history. So I believe one of the possibilities, there's a big family from China migrate from China to Taiwan about 300 years ago. That we have so many mutations that's exactly the same, which has never been reported before. So in summary, that in Taiwan, the ADPKD population, we have very high PKD2 mutations. And one of the reasons is we have founder mutations. And I believe our PKD family in Taiwan, actually PKD in clinical is a heterogeneous disease. You can have PKD1, PKD2, you can also have this novel genes, or you can also encounter this ARPKD genes. And we also have a quite percentage with these ALG8 mutations. And we perform some MLPA analysis, but not all of them yet. Actually, we can identify 5% more of cases. So the definite diagnosis rate can reach 65%. And if we calculate the VUR, it can reach about 85% of our diagnosis, which means we still have at least 15% of cases that we do not have a clinical, a molecular diagnosis for them. So the study limitation is currently we haven't finished our large insertion, large deletion, or complex gene arrangement analysis. So what we are doing now is doing some whole exome sequencing or whole genome sequencing to identify the mutation for these families. And we also encounter some intrafamilial variability, which means the clinical presentation, some of them are quite different. Some of the members, they are really mild, and some of them, they are very severe. We haven't had a good answer for them. So currently, we are doing whole exome or whole genome sequencing this year. So I hope we can find more genetic causes of this consortium. And potentially, we can also find this gene modifier after we perform the whole exome or whole genome sequencing. So finally, I would like thank you to all the clinicians that contribute these samples to our lab. And thank you very much.
Thank you, Dr. Thank you, Dr. Fang, for your excellent lecture. Now, we are open discussion. And we have an online audience and an on-site audience. So, any question from on-site audience? Do you have any question? May I ask Professor Zhang? As you showed, WDR19 is serial structure abnormality, right? But PKD1 is a serial normal structure but haplofunction or abnormal function, okay, or malfunction. But the clinical presentation in mice, the PKD1 mutations looks more severe than WDR19. But it may be due to PKD protein expression not only in cilia, in PKD, but also in pathological cell-cell interaction. Do you think that can explain the clinical difference in these two genes? Do you think their distribution may explain this?
I think it's possible. But until now, the real function of PKD1 only focus on the primary scene, yes or no? I think that this is an open question. So a lot of scientists still describe the function maybe in the basal erythrocyte, maybe in the cell content. I think it is possible. But right now, I just focusing on the primary scene because a lot of gene defect in the primary scene all cause the polycystic kidney disease. Okay. But in the reverse side, we can. It's hard to find the other genes that are not involved in the primary cilium. The other genes, they are not located in the primary sequence. The defect in this gene that causes PKD1. The gene number is relatively lower than the gene they are located in the primary sequence. So this is my strategy. But however, I cannot rule out any possibility. The PKD1 may be located in the other side there, still play some role and cause the polycystic kidney disease. Okay, that is my answer.
Thank you. Another question I want to ask Dr. Huang. Can you explain more detail? What's the edge of mutation analysis to study in PKD1 mutation? What's the edge of mutation analysis? What's their purpose and the content? What is this?
Yeah, for the edge of mutation means if you, like our population, we have a lot of PKD2, arginine AL3, stop-coding mutations. And if we assume they are from the same ancestor, it's blood. So we can use the haplotype data to reverse calculate what happened or what's the first case that has this mutation, because there is estimated a recombination frequency in each generations. So if the phasing range that we calculate is at about 250 kb, they had this 80%, they are exactly the same. So if this area is bigger, so let's say it's much bigger, let's say half of the chromosome, they are exactly the same, means they are really very close. It's only one generation, you have very few recombination happen on this site. So if the phasing region is very, very large, indicates the founder is very close to current time. So if the region gets smaller and smaller after the gene recombination, that means it's much older, or let's say 500 or 1,000 years ago. So that's the age of mutation. It's a statistic way to analyze this. It's not very accurate. Yeah.
Does it need family segregation study?
Yeah, that's why we include only 78 families. We want to have more patients from the same family. We can do some real number phasing. If we have a lot of families, disease and undiseased, we can actually manually align the phasing first, instead of if all the sample is from the different families, so the phasing will be much more difficult. So if you have some basic knowledge of the diseased haplotype, then we can do the phasing much more easy by analyzing the known family first. Then we add other families into the calculations.
Okay, thank you. Okay.
I want to ask Dr. Huang, thank you for your wonderful presentation. I'm a pediatric nephrologist in National Taiwan University Hospital, and I have an interesting case that I think is included in this PKD consortium also. This is a little girl that she was noted to have large kidneys in prenatal exam, and after birth we did an ultrasound. So from the morphology, from the ultrasound image and the MRI, we concluded that she's supposed to have the ARPKD because her kidneys volume are large, and basically the cyst cannot be seen from ultrasound image and only from MRI. So the radiologist also suggests it should be an ARPKD. But for our interest, we have by Dr. Chen Pei Long, they are interested to survey this kind of patients, their genotypes. So at first, we searched for the PKD1 gene variants, but nothing was found. And later then, they reviewed the other renal cyst genes and found that the little girl got the PKD1 variants in two PKD variants, and is compound heterozygous. And for her parents, the parents did not have any renal cysts. Her parents lived 30 years old, both of them, and they receive ultrasound exam also. They don't have renal cysts. So this is quite interesting. I was wondering, from your large cohort, did you find any similar genotype, phenotype, rare rare manifestations like this kind of children? Because if in the era before genomics was very popular, this kind of patient will be regarded as ARPKD, and probably will tell their parents the prognosis is much worse. But right now, I follow her from birth to around 3 years old. Now her kidney function is completely normal. Aside from the ultrasound still show that her kidney is very enlarged, like it's 10 centimeters in length already, similar to the adults. Yes, I was wondering if you have any other experience.
For your question, yes, we do have this family or patient, and I believe other people also have this. It's also in the literature. That means if one patient you have 2 mutations, I mean one from the father and one from the mothers, then the phenotype will be much more severe. It's very similar to what the mouse model is because for the PKD1 model, if you knock out only one allele, then in 2 years, that's the life span of a rat or mouse. They don't get sick. But if you knock out 2 alleles, then they are dead, right? So clinically, we have 2 hypomorphic mutations patient. We also have one, like let's say, French mutation plus a missense mutations. But this patient, the second patient with 1 severe mutation and 1 mild mutations, and their presentation will be much earlier. So that it's one of my patient. He received dialysis at the age of like 32 years old, because if it's 32 years ago, you ask me, I don't think it's a PKD patient, right? So it's happened. So but clinically we never see 2 severe mutation in one patient. I believe they will be dead. So that happened in the literature in our clinical practice too. I believe the Linko, Changgen, Dr. Zheng also have one of these cases. That's the father is a PKD, but the kids get GFR less than 100 at the age of 10, I think. So it's much more severe phenotype. Yeah. So yeah, we do have this patient. Yes.
In your genomic study, how much percentage of intrafamilial variability? How much?
I think that at least 10% of the family have this intrafamilial variability. It's beyond the sex. I mean, in general, the male is much more severe than the female. But in terms of liver cyst, the female is much more than the male, because it's in the literature already. But let's say we have 2 brothers, they all exactly have the mutation, the PKD1 mutation. But we have the younger brother actually entering dialysis at the age of 50. But the brother at the age of 54, I mean, he is still in CKD stage 4. So it's quite different. But we haven't have a good clue for this. And especially there are some gene modifier that proposed that there are other gene defects that can affect this PKD. So you have this PKD1 mutation. It's the main determining factors for the clinical presentations. But if you have other variants found in the genome that's, let's say, on the primary cilia, that can also affect or modify the disease progression.
Thank you. Polycystic kidney disease is a very complex disease. It's still necessary to further study in this field. Okay. Are there any questions to our speaker? Okay. If no other question, let me close this section. Okay. Many thanks for all participants in this section. Thank you.
Thank you very much.
Good afternoon.
Good afternoon. How are you?
Thank you.
一样会显示说你的简报剩几分钟，就每个人这样。会看得到。对对对，会看得到。然后底下座档就是线上，就看那边。那我就先放这里。
对，哦，他会。
Yes. Dr. Johan, Dr. Yuhan's mic is not working, so he says, I think we can host this by ourselves now. This should start very soon. We have participants already.
Do we have to share the screen or they are doing it?
Let me ask. I think they should run it.
Okay, I think they are running it now.
Okay.
We may start.
All right.
Okay.
Okay,
Welcome, everybody. It's for me a little bit difficult to see the number of participants, but I think I see 23 people in the room. We have today, except for the first speaker, a very exciting program on hemodialysis. I'm Johan van der Walle from Belgium, but I give first the word to my co-chair.
Thank you very much. I'm Ali Asghar Lenwala. I'm from Pakistan. I work for the Sindh Institute of Urology and Transplant, and I'm humbled and honored to be here. And let me introduce our first speaker. It's no other than Dr. Johan van der Walle. He's from Belgium, and he is the chair of ESPN, European Society of Pediatric Nephrology Hemodialysis Group. And he's going to talk about all the impediments, challenges, and the upcoming trends in hemodialysis. So, Dr. Johan, you want to begin?
How do I start my video? Okay, they are doing
they have
it.
started. Yes.
Good afternoon. It is an honor to be invited as speaker on this meeting. I will give you a talk on the update on hemodialysis, and the clinical practice recommendations. I'm aware this is a very heterogeneous audience. Some are trainees, some are coming from low resource countries where not yet everything is available. Some have already very advanced care, and some want to hear for future perspectives. If we are looking to the relationship between renal replacement therapy and gross national income, then this slide from Franz Schaeffer is very helpful. On the top left, you see the low resource countries who are mainly in Asia, Africa, and Middle America. On the right, you see the graph with the incidence on renal replacement therapy, where you see that in the majority of the Western world, we have the same incidence. But on the left side of that graph, you see that in many countries, and especially the countries with low socioeconomic status, renal replacement therapy is still a rare condition. Now, this slide is of course 8 years old and many things have changed. And we can be sure that in the next 8 years again, many things will be changing. So therefore, this talk will be at two levels. When we are talking about dialysis or renal replacement therapy, especially in children, we are thinking at first sight on three items. First to the top is the removal of water, sodium, and correction of acidosis. But that's not what will be my major topic today. Second is we know that they have disturbances in bone, in several hormones like parad hormone, but also this endocrine part will not be my cup of tea today. I will concentrate on the removal of waste products. And in the first phase, I will concentrate on the water-soluble compounds. Now, the talk will give you something old, something new, something borrowed, and something blue for the future. Now, something old. In 2005, Michel Fischbach and Alan Watson, my teachers in the hemodialysis, took the action to write up practical guidelines on hemodialysis. And although these guidelines are 15 years old, I will try to use them as the basis of my talk and demonstrate what has been changed since then. The first thing will be a little bit boring, but is going guideline by guideline. Hemodialysis should be delivered in a pediatric dialysis center supported by a multidisciplinary team, supports individualized and integrated therapy. There is not such a one therapy for all in children. Guideline 2, very important, is the water quality, not only for biochemical composition, but especially for the microbiological contamination. Guideline 3 asks the dialysis machine. It must be volumetric ultrafiltration control, and it must have an option for both single and double needle dialysis. The blood lines must, of course, be adapted to the child and, if possible, to the baby. When we come to the blood purification, of course, the first idea is on the small solute clearance, what's mainly done by diffusion and where urea is the best example. But we have to take in account also convection, what might be much more important for the so-called middle molecules. This is the same slide. Now, the first two that might be appropriate and should be considered as the minimal criterion for a dialysis center. Convection and hemodiafiltration, they might be considered as optimal dialysis if you can afford it. Now, to understand the difference between those three items, water-soluble molecules are small, less than 500 Dalton, and are moving from the left side to the right side. So from the blood into the dialysate. And this goes by diffusion, and very important is a concentration gradient. Middle molecules, of which beta-2 microglobulin is the example, are larger molecules. They are not benefit from diffusion, but they come into the dialysis by a convection gradient. And very important here is pressure gradient. And then we have the so-called protein bound, what are small molecules, but largely bound on proteins, and therefore very difficult to dialyze. You can only dialyze the free fraction. They are difficult to remove, and indoxyl sulfate and paracrysyl sulfate will serve as examples in my talk. Guideline 6, the vascular access. Fistula should be the preferred choice, but are not always possible, and in small children it takes a very long time before the fistula is maturated. In France, there is the experience by Bourkelot, where all small children got their fistula in one center where they were to refer to, and who had superior results to what most countries are having. Double needle technique should be standard, but it's not always possible. And extracorporeal blood volume, excuse me, should be less than 10% of total patient volume. Blood flow rates are normally between 150 and 200 milliliters. Anticoagulation is extremely important. Recently, one of my colleagues in the adult was demonstrating that without enough anticoagulation, you get a very fast blocking of the fibers. And in a second paper, he demonstrated that the so-called theory that you should with albumin preserve the fibers, that is not true, and that in the so-called evodial kidney, where you do need to have anticoagulation, anyway, up to 80% of the filters are blocked on a short term. Which dialyzer membrane should we choose? Now, the synthetic membrane is a low flux and is therefore only for the small molecules. High flux membranes are eliminating also the middle molecules, but they need to have ultra pure water to avoid infection by backfiltration. Removal of urea and other uremic toxins should be taken in account. We have some specific challenges in pediatrics. First of all, each child should be considered as a part of an integrated care program, including phases of CKD, several renal transplants, several episodes of dialysis. And if you consider like that, then PD remains the first choice because it preserves residual renal function the best, and it preserves also the vascular access in the small child, vascular access that you might need in adulthood. Chronic hemodialysis in infants is possible. It remains a challenge, but there are increasing data on acceptable results. And if you see in the next slide, you will see that up to 80% having good results. Many of those children need small fill volumes, are very difficult to ultrafiltrate, and the percentage of ultrafiltration is high. So many of those small children do need 6 dialysis episodes in a week. This somewhat older slide shows already the limited number of data that we really have, but where indeed up to 80% of patients have an acceptable result. Very important in those children is, of course, the size of the catheters. And this table demonstrates which kind of catheter and which length you should use for the different types of children. There are some new machines on the horizon. Carpe Diem is a machine who was developed for CRRT and is also possible to have slow dialysis with. It is very good for small children because it has a small fill volume of about 28 milliliters. But it is not a superior dialysis machine, and you cannot do hemofiltration with it. It serves for children under the weight of 8 kilograms. Nidus is an English machine developed for neonates and is a CRRT and not really a hemodialysis machine, but it's a solution for the extremely small children. In contrast with this new development, there is an increasing gap where we are losing appropriate lines in the age group between 8 and 20 kilograms. Now, what is new? New is that we are moving more and more, not only on theoretical, but also on scientific grounds, from major attention to the water-soluble contents to the protein-bound and the middle molecules. New is also that we are investing more in nutrition. Nutrition is an essential part of dialysis and of dialytic patients. There is a pediatric renal nutrition task force that was created by Roxanne Ashcroft from Great Ormond Street, and already 3 papers have been published and many others are in preparation. Although I would rather claim that all the wisdom is in my head, I have to admit I'm borrowing it from others. And then I'm coming again to the same guy, Michel Fischbach. Michel Fischbach demonstrated already a decade ago that daily online hemofiltration promoted catch-up growth in children on chronic dialysis. You see on the left side the growth curve. In the middle, you are seeing the growth velocity. This effect was correlated with 2 changes, daily hemodialysis and HDF. He could do it also in other children, and his first papers were in 20 patients, where you see here 4 characteristic curves. It is not surprising that intensifying dialysis had good results. The Tassin experience in Lyon with 3 times 8 hours in a week in adults in the past had already demonstrated that. In children, several centers have tried to develop their own way of intensified hemodialysis. You have short daily, what is mostly 6 times 2 to 3 hours, like Fischbach and de Camargo. You have nocturnal hemodialysis, Hoppe, Tumfat, and the group of Müller in Berlin. You have nocturnal daily hemodialysis, what's published by the Toronto group of Geary, and frequent home hemodialysis that is becoming very popular with the new machines published by Hotti from the Great Ormond group. All these things are not related to better dialysis of urea and small volume. So let's look to uremic toxins and especially the beta-2 microglobulin. Now, how can we explain that? We are going to, in my slide, from right to the left side. Low flux is not able to evaporate middle molecules. high flux is able to do it, but only in a limited phase. If you are going with more pressure, increasing the convection, and then you are in post-dilution HDF, then you eliminate much more of these middle molecules. Now, dialysis is always something related to duration, blood flow, and the magnitude of the filter. On the left slide, you see that the longer your fiber is, the better your epuration. For urea, that goes very fast. Vitamin B12 is slower, and inulin is still slower. So for inulin, you need to have a larger fiber length, so a larger filter. On the right side, you see the difference between low and high flux membrane, where in low flux membranes, you hardly are not filtering beta-2 microglobulin. Roxana Shkrof started a multi-center study in Europe on the outcome of hemodiafiltration. And in her studies, she showed that CIMT, what's a parameter of cortical medial thickness, and so of vascular disease, that in the hemodialysis group, there was over 1 year, there was progression of this bad parameter, where in the hemodiafiltration group, the result stayed stable. If you are looking to height standard deviation, and growth is, of course, the ultimate parameter of anabolic, then it's clearly that the patients with HDF are doing better. If we are looking to blood pressure control, again, the patients with HDF are doing better. And if we are looking to beta-2 microglobulin, it's clearly that the levels are lower in HDF patients than in conventional hemodialysis patients. Although we have to refrain to say that there is a causal correlation, we have anyway to admit that there's a clear correlation. Now moving to the third part, the proteins-bound uremic toxins, where indoxyl sulfate and paracresol sulfate are the best known. My colleague Evelyn Snowart studied in patients with CKD, stage 4-5, and in patients on hemodialysis. And you see that patients with CKD less than 30 milliliters GFR have already a significant increase of their uremic toxin, but it goes exponential up when they are starting to do hemodialysis. What means that the hemodialysis is not treating appropriately those uremic toxins. Now, there's a clear difference. The middle group has still residual renal function, and although the GFR was extremely low, and so the patient needed hemodialysis, you see that uremic toxins are much lower in those patients. So we really have to try to maintain residual renal function. If we look now to the difference in treatment on the different uremic toxins, then you see, and we are going to the left graph, where the low flux kidney has poor clearance of beta-2 microglobulin, the high flux is doing better, the HDF is doing really significantly better. If you are looking to the protein bound, then there is no significant difference between the three groups. So HDF has no added value for the protein-bound uremic toxins. Now, besides HDF, there is another thing that is also important, of course, and that is the duration of dialysis. patients need times to mobilize uremic toxin into the plasma. And this is clearly demonstrated here from ureum to beta to microglobulin. And the longer you are dialyzing, the more you are dialyzing. If we are considering now more in depth the protein-bound uremic toxins, and then we are concentrating on indocil sulfate and paracresol sulfate, who have an almost 100% protein binding, then you see here that the dialyzer clearance shows an inverse relation with the percentage of protein binding. What is logic? You can only dialyze the free fraction. So, in concluding, it's obvious that we should study more on uremic toxin, and we should do it in children, because children have the unique opportunity that growth is an objective parameter of catabolism and anabolism. Now, something blue. And then I'm come back to one of my first slides. If we look to that old guideline, where there was on that moment a lot of consensus, but still very little evidence, evidence has been shown in the last years. And so to conclude, how can we get adequate and even optimum dialysis? We should not only titrate our dialysis to urea. Other uremic toxins should be considered. Dialysis modality should deliver normal blood control, if possible, without antihypertensive drugs, and preserve myocardial morphology and function. Dialysis frequency and duration must be adjusted to the tolerance of ultrafiltration to reach dry weight. Ultrafiltration rate should not exceed more than 1.5 weight per hour. What means if it's more than 1.5%, you should prolong your duration of dialysis. Blood volume hematocrit lines will guide us to safe ultrafiltration. Diet is important, and diet will become more and more important, not only to avoid malnutrition, but also diet is one of the major tools that we have to decrease the production of uremic toxins in the intestine. Urea kinetics. 15 years ago, KT over V was the golden standard. It remains a very good parameter for observation in studies. But KT over V shows only urea and does not show the full spectrum of dialysis characteristics. But it's helpful to avoid that you would dialyze too little. Don't forget the PCR calculation to maintain the child in good protein catabolic rate. Many think that if the results are getting better, your child should put on a very restricted diet and is then getting in fasting. This is often aimed for because one wants to stay with 3 dialysis episodes in a week. The advice is keep the child in good nutritional state and, if needed, prolong or increase the frequency of dialysis episodes. Ultrafiltration should not be too fast because then you get hypertension and hangover after dialysis, and we should not underestimate disequilibrium syndrome, especially when urea is dialyzed too fast. So all these points were in the vision of the paper in 2005 and are nowadays still true. Thank you for your attention.
Thank you very much, Dr. Johan. It was an excellent talk and gave a lot of insight on the way and how we can improve our dialysis for children. Our next speaker is Dr. Johan An. He is an assistant professor in Seoul National University, and he is going to tell us about how we manage volume overload in pediatric patients who are on hemodialysis. So, Dr. Johan.
Thank you. Hello, everyone. My today's topic is volume overload in pediatric patients with hemodialysis. I will discuss clinical consequences of volume overload among hemodialysis patients, assessment, and management method for this. We usually perform conventional hemodialysis 3 times a week. Patients gain their weights between hemodialysis sessions. This kind of fluid retention causes chronic hemodynamic stress. It includes hypertension, congestive injury, and cardiac remodeling. On the other hand, patients experience acute weight loss during hemodialysis sessions, and it causes hypertension, electrolyte imbalance, and ischemic injury. Intradialytic weight gain, IDWG, is defined as patient weight gain between hemodialysis sessions. Because clinicians try to achieve the dry weight of patients, IDWG is usually equal to volume overload. In the report on children with hemodialysis, IDWG over 4% was significantly relative with left ventricular hypertrophy and increased blood pressure, as you see. Volume overload is known as significantly associated with all-causes mortality and cardiovascular mortality in adults with hemodialysis, and mortality decreases in the absence of volume overload, as you see. Sometimes there would be discrepancies between IDWG and volume overload. If volume overload is higher than IDWG, chronic hemodynamic stress increases. In contrast, if volume overload is lower than IDWG, hypotension often occurs during hemodialysis sessions. So, we need to measure patient's dry weight properly. Traditionally, clinicians estimated dry weight of hemodialysis patients using clinical signs such as peripheral edema, blood pressure, and IDWG. However, these parameters have limitations, especially in pediatric patients. Recently, some objective methods to assess fluid state have been introduced in the clinical setting. This includes bioimpedance analysis, lung ultrasound, inferior vena cava diameter, and so on. Bioimpedance analysis, BIA, measures total body water using multi-frequency electric current flow. It is non-invasive, quantitative, and easy to apply. But until now, it is not widely distributed and has limited data for clinical outcomes in children. This is the hydration reference plot of BIA for adults from large-scale study performed in 2008. It was designed to be compared with health populations matching systolic blood pressure based on hydration status. As you see, abnormalities in fluid status or blood pressure were 10, 15, and 13%. In a validation study for BIA in children, there was a strong correlation between total body waters estimated by conventional methods and those by the BIA method. In a study with 30 children with CKD stage 5, there was a discrepancy between blood pressure and hydration status. 25% of children with hypertension did not have overhydration assessed by BIA. Instead, overhydration assessed by BIA correlated with peripheral pulse pressure and terminal proBNP and left ventricular end-diastolic diameter. Our group evaluated the efficacy of BIA in children with peritoneal dialysis or hemodialysis. The patient with fluid overload had a shorter duration of dialysis, higher proportion of uncontrolled hypertension, and they got a more number of antihypertensives compared patient without fluid overload. B lines in lung ultrasound can provide semi-quantitative estimation of interstitial lung fluid. It is a quick, non-invasive, and easily available tool, but this method is relatively observer-dependent and could be affected by underlying heart or lung disease. One prospective study revealed that lung ultrasound B lines was sensitive to detect subclinical fluid overload in infants and children with acute kidney injury or end-stage renal disease. And another recent study showed that changes in B line numbers were directly correlated with IDWG and direct weight loss in children with hemodialysis. inferior vena cava diameter and its collapsibility index is another objective to detect intravascular volume change. As it is measured by ultrasound, it is inexpensive and non-invasive, but it could be observer-dependent and difficult to measure, especially in children. One prospective observation study compared lung ultrasound B-lines, IVC parameters, and BIA in 13 children on dialysis. In the study, lung ultrasound was superior to IVC diameter and BIA to detect volume overload. I will move on to the management of volume overload. It includes dietary sodium restriction, use of low dialysate sodium, diuretics, intensified hemodialysis schedule, and implementation of non-invasive methods to guide dry weight reduction. The KDIGO guideline recommends low salt diet in the normal range according to age. But this is difficult in hemodialysis patients, especially in children, as you know. Low dialysate sodium could reduce free dialysis blood pressure and IDWG, but it could lower serum sodium concentration and increase hypotensive episodes and cramps during hemodialysis sessions. In patients with residual kidney function, we can use diuretics to control volume status. Longer duration or frequent hemodialysis schedule could be useful to reduce the volume overload. For example, intensified hemodialysis as 4 or 5 times a week can reduce both IDWG and intradiuretic weight loss. In this regard, hemodialysis may be the best physiologic method. However, it is not yet widely used, and it is not applicable to infants and young children. Is a problem. Randomized control trials in adults with hemodialysis revealed BIA-guided fluid management would be effective to control fluid overload and blood pressure. In addition, it is effective for improving cardiovascular parameters such as left ventricular mass index and arterial stiffness. We also demonstrated that BIA-guided dialysis prescription change was effective to reduce overhydration and numbers of antihypertensives. In summary, volume overload is a major risk factor for cardiovascular problems and mortality in children with hemodialysis. Objective measures of fluid status are important to improve clinical outcomes in children with hemodialysis. Until now, there was limited data on the various methods to detect volume overload, including BIA, lung ultrasound, and IVC parameters. Management of volume overload includes reduction of sodium intake, diuretics, optimization of hemodialysis schedule, and implementation of a non-invasive method to guide dry weight reduction. So, large-scale studies are needed to confirm the proper method for assessing and managing volume overload in children with hemodialysis. Thank you for your attention.
Thank you very much, Dr. Yuhan. That was an excellent presentation. Now we have 2 free papers, and we can take all the questions after the 2 paper presentations. The first paper is by Dr. Hui Lan Chen. He's from Taiwan, and he is going to tell us about his experience of intermittent hemodialysis in pediatric intensive care unit, a 20-year single center study. So, Dr. Chen.
Thank you for introduction. Good evening, everyone. I'm Chang Hui Lan, one of the fellows of Taipei Veteran General Hospital, Taiwan, and I'm grateful to be given the opportunity to present here. My study is titled at analysis of critically ill patients received intermittent hemodialysis in pediatric intensive care unit, 20-year single center study. Before I begin, I also wish to state that I'm the primary researcher for the study and I declare no conflicts of interest. Acute kidney injury is a multi-organ dysfunction syndrome in critically ill patients and associated with high morbidity and mortalities. And renal replacement therapy is one of the most important modality in treatment of acute AKI in the ICU. And intermittent hemodialysis is one of the modalities of the RT treatment and is available, it can be used in the hemodynamic relatively stable patient, and it can easily remove the small dialyzable molecules such as the electrolytes, certain drugs and toxins, and the modality of the modality of the RT or the timing of the RT for the AKI treatment is there is no optimal treatment of the AKI, and modality of the RT, the dose or the timing of the RT has been event from the patient survivor. And our objective is to analyze the outcome of intermittent hemodialysis in critically ill patients and compare in 2 groups. Sorry. And the way we did our study is a retrospective case study, and which includes all the patients who underwent intermittent hemodialysis in our PICU, and the date of between 1st January 2000 to 31st December 2020. The data are analyzed and collected according to the patient demographic and patient characteristic, including the hospital length of stay, and results were compared in 2 groups, and primary outcome was mortality. Throughout the test, data were expressed as means plus or minus standard deviation, and median interquartile range, and percentages as appropriate, and p-value less than or equal to 0.5 is considered to be statistically significant. SPSS for Mac versions 27 software was used for all the statistical analysis. Results over the 20 years, we have the 107 patients, and we divided into the two groups, and one is 2000 to 2009, and one other is 2010 to 2020. In first group, there is 73 patients, and in second group, there's 34 patients. These figures are showing the percentages of cases per years. This is the characteristics, results of the characteristics of the gender, and we found that there is, in 2000 to 2009 group, there is female is predominant for 56.16%, and in 2010 to 2020, male is predominant 58.82%, but there is no difference between the two groups. This is the results of the patient's characteristic age. Age was stratified into groups, and from 0 to over 30 years above, and the median age was 18.0 in first group and 19.5 in second group respectively. And we found that in later group there is 17.6% included in the age of a 0 to 1 year age group, and compare with another group in 0%. However, there is no significant difference between the two groups. And this is one of our cases with the lowest body weight. She is a 1-month-old female, and diagnosis is renal coloboma syndrome, and it's a rare genetic condition characterized by the optic dysplasia and renal hypodysplasia. His body weight is at the time is 1.8 kg, and this is our hemodialysis machines. This table shows the results of the BUN creatinine, and the data of BUN creatinine collected before the initiation of the hemodialysis, and we found that in 2010 to 2020 group, both the levels of means of BUN creatinine, serum creatinine and serum urea are lower than that of in 2000 to 2009 group, because 17.6% of the patients is less than 0 to 1 year of age included in second group, and this may be influence the mean of the BUN creatinine, and there is no difference between the two groups. This is the results of the morbidities, and in two groups, sepsis is one of the most important morbidities, and there is 68.5% in first group and 91.2% in second group, and there is significance between the two groups. Another one is the renal diseases, and 79.5 in first group and 67.6 in second group. And however, we know however, there is a little bit reduced the percentage in second group. Maybe there is obvious reduce the number of SLE and KQ group and in later group. So this may be the reason. And SLE group, there is a significance difference between the groups. Another one is the cardiac diseases. And we found that in 2010 to 2020, the percentage of the cardiac diseases is reduced than the previous 2000 to 2009 group. This may be the prenatal diagnosis of the congenital heart disease and the early terminations of the pregnancy, maybe the one possible reason, and but there is no statistically significance. Another important is genetic diseases, and we found that the 2010 to 2020 group, there is 22.6%, and compared with the 2000 to 2009 group, that is in 6.8%. It's higher than the previous group, and maybe the genetic disease is early detection by the genetic testing, and the early diagnosis is the one possible reason, and there is significant difference between the two groups. This is, we assess the odds ratios for the associations between the renal diseases and sepsis. And in both groups, there is percentage of the renal diseases in sepsis is 63.8% and 67.7%. The odds ratios is 0.271 and 1.01 respectively, and there is no significance in both groups. This is the results of the mortality. Our overall mortality in 2000 to 2009 is 9.6%, and 2010 to 2020 is 14.7%. And there is no difference between the two groups. Most of the cause of death are sepsis. And this is the mortality by gender, and we found that there is no difference between the two groups. Okay, this figure shows the mortality by the age group, and in 2010 to 2020, 3 out of 5 death belongs in the age of 0 to 1 year, and these patients are 4 days old and 4 months and 10 months old. Most of the mortality are cause of deaths are the sepsis. But there is no significance between the two groups. This is outcome mortality, and we analyze this logistic regression of outcome mortality of the patients. And two groups, we found that in 2000 to 2009, and only the odds of May is 1.33. It means that the male is more 1.3 times more higher than the female, but there is no significance. Other length of hospital stay and age in both groups has no correlations with the mortality, and there is no significance. We analyzed the logistic regression analysis to factor affecting the outcome mortality, and we found that sepsis is the most important morbidity for mortality, and the odds ratio is very high, and in both groups, but there is no significance for significance. Another one is renal disease. Mortality in renal diseases in 2000 to 2009 is 4.7%, and 2010 to 2020 is 4.4% less than no renal diseases, and in this group, this is statistically significant. Another is cardiac diseases. In 2000 to 2009, the odds ratio is 12.969, and it means that the mortality in patients with cardiac diseases was estimated to be 13 times more often than the non-cardiac diseases. This is significance. But in 2010 to 2020, even the odds is 1.88, but there is no significance. Another is genetic. In 2010 to 2020, there's odds is a 2.276, but it's not significance. Okay, our study of our study limitations for our study is our small sample size. In fact, that it was the retrospective. To counteract this study, we may include a future study may include the long-term dialysis dependency or 1-year survivor, or incorporate with the multi-center involvement, including the multiple regional and rural hospital. Discussions, acute kidney injury is increasingly common in ICU patients, and is greatly increase the risk of chronic kidney diseases. Renal replacement therapy in ICU setting can be provided continuously or intermittently by using the process of hemodialysis and or hemodiafiltration. But these modalities have some have advantages and limitations. And intermittent hemodialysis is less expensive, can be administered hemodynamic relatively stable patients, but in critically ill patients, dialysis-associated hypotension is adversely affect the remaining renal function. CRT and the continuous technique continuous technique allows the clearance of allows the control of the urea and the removal of the solute with the greater cardiovascular stability, but though it is more expensive than the intermittent technique, and it can be preferentially used approach for the critically ill patients with hemodynamic unstable. And today, no modality of the RT shows clear superiority over the others in terms of survival or the recovery of the renal function. In our study, gender, age, and mortality were not differ in both groups, and we found that in 2010 to 2020, 6 patients is less than 1 year of age, and age received the hemodialysis, and this means our improved patient care and more experience have resulted in the acceptance of early interventions of intermittent hemodialysis in younger patients and patients with more morbidity. So in critically ill patients, and intermittent hemodialysis may be benefits. And 2010 afterward, we noticed the reduced number which received the intermittent hemodialysis. It may be one reason is the most of the ICU patients are critically ill and hemodynamic unstable, though receive CVH or CVH-TF. This might be the one reason. In our study, sepsis is the main cause of mortality, and the sepsis is the most important morbidity in critically ill patients in ICU with the AKI, and this is further investigation is needed for modality of the RT in treatment of the AKI. And conclusion, selections of the RT modality in the ICU setting remains based on the clinical status of the patients and coexisting medical conditions and local expertise and the resources available. And further study with the longer period of follow-up is needed to assess the effect of dialysis modality on renal outcomes. These are my references, and thank you.
Thank you very much, Dr. Chen. Now our next speaker is Dr. Wang. He is also from Taiwan, and his paper is about personalized shared decision making in choice of dialysis modality. So, Dr. Wang, you have 15 minutes for your paper.
Thank you, the chair's introduction. I'm Dr. Xinhui Wang, come from Taiwan. My topic is personalized shared decision making in the choice of dialysis modality in children with end-stage renal disease. As we know, in patient-centered healthcare, shared decision making is a key component. And between the healthcare professional and the patient, shared decision making is a process and interaction between healthcare professional and the patient to make decisions based on clinical evidence to select test, treatment, and care plans. And the other hand, to build a value-based care with patient preference and value, and to balance risk and expect outcome. The search of SDM is based on the search of latch. Healthcare professional is the expert on the medical evidence, and the patient is the expert on what matters most to them. The SDM have 6 important steps, steps by steps. The first step is to invite patient to participate, and the healthcare professional present options and provide information on benefit and risk, and to assist patient in evaluation options based on their goals and concerns, and to facilitate the deliberation and to make the decision, and to assist with the implementation. However,
the SDM in child application is poorly understood now. Unlike competent adult patient decide for themselves, the principal participant is the patient's surrogate. So there are limitations on decision-making authority in child. To address the gap and improve the SDM in pediatric patients, we can see the literature review, and we can find a 4-step framework in the literature to improve the shared decision-making in pediatrics recently. In the kidney failure patient, SDM is the treatment, and in the treatment of kidney failure, it is important because the number and the complex of disease involved in kidney failure is complex and much number. So in the patient with the AKI and the CKD stage 4 and 5 and the end-stage renal disease, SDM is an important tool. And in end-stage renal disease, the treatment option include available dialysis modality and the transplantation, and not starting dialysis and the continuous medical management, and the time-limited trial of dialysis or stopping dialysis or reaching end of life of care. For child with AKI, CKD, and end-stage renal disease, the SDM is more difficult than adult. Taking such children should have a multidisciplinary team because the involvement in child with end-stage renal disease more than pediatric patient. They also include parents and maybe also other family members. So our purpose of study is focused on the choice of dialysis modality in child with end-stage renal disease. We want to establish a personalized SDM process with family and a child-centered choice of dialysis modality. We want to improve the cognitive ability of the parents and the pediatric patients, including the medical condition, prognosis, and the available treatment options. So the available modality were hemodialysis and peritoneal dialysis. We use many tools to facilitate the SDM process, including the questionnaire, video, education sheets, and the tool to establish dialysis concrete concept and structured interviews. We need a team member, including pediatric nephrologist, experienced nurse, dietitians, and the social worker, and many tools to facilitate SDM. We want to establish a patient and family-centered flow sheet. This is our patient and family-centered flow sheet. We divided the children with end-stage renal disease by the age. They are divided to preschool and the school age and the teenagers. We perform the pre and the post questionnaire, and we use tool include video education sheet and the tool to establish dialysis concrete concept. And about the teenager, the most important is clear daily schedule because they want to arrange their own time. So clear daily schedule is very important. And then we have a structured interviews and finally to make the decision. So how we use tool to establish dialysis concrete concept in the child and the preschool child. How to explain the hemodialysis machine or process to children. This is a hemodialysis machine, and how to explain to the children. We want to use the concept of a superhero graph. Superhero graph can he can flash, but the flash needs to be recharged.
So we explain the child that the hemodialysis machine, like a recharge or like a fuel station, can make the hero graph refresh. So this is a concrete concept. And how to explain the peritoneal dialysis to children? We use some door and some cute tool. Like this, we can see the door with a peritoneal tubular in the abdomen. And this is another demonstration to clear and easy to explain the peritoneal dialysis. And we also use the 3D print to make some tool to let the family and the child to know how they can do peritoneal dialysis at home. And then about the teenage, the daily schedule is very important. Hemodialysis, they will have per week 3 times, and the per section 4 hours. And the peritoneal dialysis, they should do by themselves, and 4 times a day or a night change. So the schedule is very important to teenagers. And the follows, we have a structured interview. The structured interview should be performed many times, and start with a choice talk. A choice talk will convey awareness that a choice is exact. And then the option talk will talk more about the treatment option. And along the deliberation process, the patient and family will give a decision talk. The decision talk will support the patient and to explore what matters most of them. And then they will do the decision making. And the decision making will consider the age and the underlying etiology. And the most important is patient's value. Our model component analysis include create choice awareness, provide information, describe treatment option, and learn about the patient question, patient preference, and finally determine the next step and make the decision. This is a different age and a different underlying disease and a different patient value will choose different dialysis modality. Maybe peritoneal dialysis, maybe hemodialysis. So patient-oriented outcome and the patient-reported experience are most important in the value of SDM. Through the SDM process, can learn about health and understand the pros and the cons of different options and build a lasting and trusting relationship. And they will more likely to follow through on their decision. So SDM effect can increase patients' knowledge and develop a partnership between healthcare professionals and the patients, and they will have more information about the treatment option, and they will consideration the potential consequence of each one, and increase the consistency between patient decision and their value, and make a decision by consensus. And in the child, they have more knowledgeable and better prepared to dialysis. And they will understand what we are trying to do and build a trusting relationship between healthcare professional and the child. And this may improve self-management and increase the dialysis satisfaction. This is our model's component analysis. The analysis, our model includes 8 components, and this is the trend in the year about the SDM model. So our conclusion is dialysis options have different level impact on children and the parents' physical and the psychological condition and the social life, and we establish a
a personalized SDM for child and the parents. Personalized SDM in dialysis choice has potential to improve self-management in child, and the high-quality decision can increase the dialysis satisfying and the success rate. And the further aspect we want to do in SDM in child with ESRD, including we want to build a more real model of hemodialysis to make a child understand what is hemodialysis. And we want to use more qualified evaluation method other than questionnaire. And after decision making, we want to focus on improved practice and the care of dialysis. And finally, we want to discuss other options than dialysis, such as palliative care or end of dialysis. Okay, thank you for your attention.
Thank you very much, Dr. Wang. Now the floor is open for any question. There's one question by Dr. Mishra. It's to Dr. Yuhan. He's asking if you could use diuretics even when child is on maintenance dialysis.
Can you hear me?
Yes.
Yeah. The trials in order to show that use of diuretics have benefit effect in patient with hemodialysis. But I think it is used in children considering the side effect of diuretics. For example, furosemide have a side effect of including hearing loss and nephrotoxicity. So in our hospital, we sometimes use diuretics for short period in patient with poor control of volume and blood pressure. Yeah.
Dr. Vandivelli, you want to add anything about this, the use of diuretics?
It's a very interesting question, and to be honest, we have to look it in three totally different ways. The study has still to be performed. I think what Dr. Johan said is correct. I mean, if you're giving furosemide, you might get toxic levels and then you get ototoxicity. But of course, you can adapt the dose to the degree of CKD, and then you do not have that. The second item is that if you give diuretics, then, and I mean you have then to give them in what's a very new word, but in chronotherapy. Of course, you do not have to give it immediately after the ultrafiltration, but the next day you will have beneficial effect on your diuresis, and therefore the next time you need to ultrafiltrate less, what of course would be better for your dialysis efficiency. And the second item, diuretics are sodium excreting, so you will have lower blood pressure, what's again beneficial. And the third thing is, if you heard my talk and that persistent diuresis coincides with higher excretion of uremic toxins, you would also say it's beneficial, but it's thinking. There is not one study who proves it. And you will not be able to demonstrate that in the adults because the majority of adults are going to anuria, where in children, majority are uropathies, and they keep on to have a certain diuresis.
Thank you. Thank you. Yes, I would second this, that the use of diuretic is based on the residual renal function. And in children, since mostly the etiology is obstructive uropathies and they preserve their residual functions for some time. So giving diuretics to children, especially with ESRD, if you increase the urine output, even by a few hundred mLs, that would give them more space to drink a little bit more water. They would excrete more sodium, and then they can eat a little bit better. But obviously, the problem with toxicity is always there, and that has to be monitored, and the dose has to be tailored. Any other question from any other participant about all the talks that we have heard?
If I may, I would like to go to the first presentation about the acute kidney injury. And of course, I was very intrigued by the fact that in the last decade, they had only half of the patients on intermittent hemodialysis. And then it became clear that they had probably more CRRT patients. But if I would give an advice, I think even with those data that you have, you should go for publication. Maybe you should demonstrate how many patients were on CRRT and hemodialysis, because in the Western literature, people are only reporting nowadays on CRRT, and that's because nephrologists have become lazy and they let the dialysis do by the intensivists. Where I think that both advanced peritoneal dialysis, intermittent hemodialysis, and CRRT have advantages. But since nobody is daring to publish anymore about intermittent hemodialysis, people forget it. I think it's safer to use an experienced nurse with a very high qualified machine than to let it do by somebody CRRT who is not experienced in it. And CRRT, you need to have continuous anticoagulation, what is also a big disadvantage.
Very
big
true.
Disadvantage, sorry.
Dr. Vendveli, in the European guidelines, the fistula first, the message is well taken. The problem is with the smaller children. Do you think that these catheters versus the artificial AV grafts or using other bigger veins, like one in the thighs for fistula, how would you say that?
In a very well educated and developed country like Belgium, everything goes wrong. What means that a young child with CKD is not entering immediately in university center. If he's not in end-stage renal failure, it might take some time. And everybody's putting in perfusions, punctures, and they are losing the capacities of having afterwards fistulas. I think what we should do, and I mean that's the same in Karachi, I mean not every patient is seen immediately in your center. We have really trained general pediatricians and anesthesiologists when the child goes with neuropathy to the OK, that they have to preserve the vascular access because that's the life line of the child.
True, very true. Okay. Dr. Yuhan, you've demonstrated that the lung ultrasound is better suited to diagnose volume overload, even better than other modalities. You can do the ultrasound of vena cava and vena caval collapsibility. Would you like to comment a little bit further on this? The lungs tend to show, the ultrasound with the B lines and the A lines that you have shown very well. It's so difficult in clinical practice to see those lines specifically. Would you, what is your experience? Do you regularly do these lung ultrasounds yourselves, or you rely on other radiologists or anybody else to look at it?
Thank you for your question. Yeah, it is very important because the benign assessed by ultrasound need skilled clinician or technician. But I cannot try benign assessed ultrasound in my hospital. In my hospital, we used the BIA assessing volume overload because it is very user friendly. So nursing team in our hospital pediatric hemodialysis center usually check the volume status in patient with hemodialysis or peritoneal dialysis. Some reports showed that B-lines on ultrasound is more accurate for assessing fluid overload, especially in European countries studies. But I don't have experience about that. Yeah. Sorry.
Okay.
Yeah.
Thank you. Any other questions from any other participants? I guess none. So I think it's about time.
It was too difficult or it was too easy. There are only two conclusions. Or they are too tired, I think.
Yeah, it's almost the end of the day for them. So
I want to thank, I cannot thank myself for the speech, but I want to thank Dr. Johan, who really gave a very good overview. I mean, everybody should carefully look back afterwards to his presentation, how to manage it. It was very practical. Congratulations. I think we had two very interesting presentations. And looking forward to see you once face-to-face on the next Asiatic meeting. Bye.
Thank you.
Okay.
Thank you very much.
Thank you very much.
Thank you.
Okay.
Bye-bye.
Bye-bye.
Bye.